but because of the acute situation, there was no reporting and there was no way we could read a CT online. This patient had persistent fever. She was noted by her pediatric team to have EBV IgM positive, and she was diagnosed to have infectious mononucleosis and discharged a couple of weeks after local admission. However, her pain increased and she was then admitted locally once again, and a bone marrow was done to exclude any malignancy. The bone marrow was reactive, and then 8 weeks into the illness, this child began to develop nodular, tender lesions in a linear fashion. The lesions were extremely tender to touch. I'm sorry, I don't have any picture for you here. We entertained an initial diagnosis of COVID because of the abdominal pain, the persistent fever, and the times that we were living in. However, there was no acute contact of this patient with the case of COVID. She was COVID RT-PCR negative. Her antibodies were also negative. So we called the child in and we reviewed the CTs, and our team felt that the child had bilateral renal infarcts. And then we went ahead and did an angiographic study, and this child turned out to have classic polyarthritis nodosa. Very interesting. She had multiple abnormalities in the branch renal vessels. We gave this child 6 doses of intravenous cyclophosphamide, which was again extremely challenging because our hospital wanted a negative RT-PCR report for both the child and the attendant at every visit. So this child went ahead and had all these things done. She was given 6 doses of cyclophosphamide, did very well. And then we wanted to put this child on maintenance, and she's perhaps the only child in my clinic where we saw that she did not have the normal TPMT enzyme. It was mutated. And so we elected to place this child on mycophenolate. She's doing very well and she's in remission. So though polyarthritis nodosa is very rare, it can creep upon us, and these children can present with significant abdominal pain and prolonged fever. What are the other areas where we often have a crosstalk between nephrology and ourselves? Well, we have this very interesting condition that is called TINU, tubular interstitial nephritis, along with uveitis. We've seen only a couple of children with this condition. It is rarely reported and constitutes 2% of all causes of uveitis in pediatrics. Now, how do these children present? They present with bilateral acute anterior uveitis. These children can even have a hypopion in the anterior chamber. The most common cause of acute anterior uveitis is a child who's HLA-B27 positive, and this child was negative. And then when we looked at the urine, we found that the child had sterile pyuria, and additionally, when we asked for the beta-2 microglobulin, this was significantly elevated. And this patient had a renal biopsy, had acute interstitial nephritis and uveitis. We managed this patient with methotrexate and steroids, and this child is in clinical remission. So from a rheumatology standpoint, it is so important to look at the urine and look at the serum creatinine in children who have so-called idiopathic uveitis, because it is very easy to miss the nephritis in these patients. Additionally, the two may not occur together, and nephritis can even occur 1 year after the child develops acute uveitis. So the message for these patients is that we need to very carefully follow up. Sarcoidosis is again an unusual disorder that we see in children, but occasionally we do. It is a multi-system, non-caseating granulomatous disease that can affect any organ. And here's a child who presents to us at the age of 2 years, who's now 18 years of age. And can you see this Sargo type of nodular rash, which is very faint, which is seen on the child. And the hallmark of these children actually is that they develop large tenosynovitis and swollen joints without significant pain. So these children need to be picked up early. The commonest manifestation of sarcoidosis in the kidney is the child develops granulomatous interstitial nephritis, and these children are well treated depending upon the organ involvement, either with early onset steroid, methotrexate, or even in some children using monoclonal antibodies to TNF. If these patients are left untreated, renal failure is a common complication. So we need to be aware about looking at features of not only calciuria, but also looking at active urinary sediment. This is a very nice review of 36 children. This is one of the world's largest series who had renal sarcoidosis. And you can see that a majority of the children had granulomatous interstitial nephritis, and they had several other features, but heavy proteinuria has not been commonly reported in the child with renal sarcoid. We have to be careful when we use drugs in rheumatology because they can have side effects on the kidney. In early years, in the 60s and 70s, gold and penicillamine would cause less improvement in the rheumatoid arthritis and much more interstitial nephritis. But those drugs are thankfully banned to history. And today, the commonest side effect we see, especially in adults, is the patient on long-term NSAIDs. We have to be careful when we use CNIs. Occasional reports of vasculitis, especially in the kidney, has been reported in patients who are on anti-TNF therapy. And of course, we need to learn how to adjust the dose of patients who have impaired renal function. Several of the rheumatological drugs needs to be carefully handled when we look at renal function impairment in the context of prescribing for these patients. Thus, ladies and gentlemen, I would like to conclude by stating that the advances in medical science today are tremendous. Specialties bring a lot to the table, but each specialist seems to wear a very narrow hat. So I hope that together we can give the child the best care, and we need to gather our teams around us so that the child gets the best available. And thank you so much for your time, your attention, and to Dr. Hemant once again for the invitation. We have a wonderful rheumatology team in our hospital. We have DNB students who come for training. We run an IAP fellowship program, and we have a vibrant team, and hopefully we are able to make a difference in the life of the children who come to our care. Thank you.
Thank you so much, ma'am, for your excellent discussion over this pediatric patients with some nephrology problem. We nephrologists come across all these like age of, we generally come with the age of 14, 15, 16. And you rightly said that if you pick this patient at even earlier age, then the morbidity can be reduced. And now the session is open for the question.
I have a question, ma'am. Ma'am, here.
Oh, sorry.
So, ma'am, actually, I get a lot of adolescent girls with SLE who require endoxin, cyclophosphamide, because they have class 4 lupus, and generally we see that they respond very well. So I've always wondered like how aggressive we should be in oocyte preservation in such cases. Should we give lupoprolide? Should we not give in these cases? Because normally our patients, at least I counsel them, but because of the cost, we generally don't give. So in your this thing, ma'am, do you also give, or how?
So, you know, the gonadal toxicity dose of cyclophosphamide is reported to be a total dose of about 6 to 7 grams. But we are not reaching that number at all because we are not using the NIH protocol for children with lupus nephritis. We currently use the Euro lupus nephritis trial dosing, which is very limited, and we would often complete 6 doses before we hit about 2.5 to 3 grams. So in our practice, we are not using leupride. There's a very good paper by Brunner 4-5 years ago, Hermine Brunner from Cincinnati, where they have shown that the timing of the leupride has to be very careful with the cyclophosphamide. Otherwise, paradoxically, you can worsen the ovarian reserve. So we need to be careful, and perhaps the uses, if you need to go very aggressive, for example, in an ANCA-associated vasculitis patient, where again, we actually tend to use rituximab now, where you may want to do an ovarian preservation. So short answer is, in our practice, because we use a lower dose, we are currently not using it.
And your index was quite high. That was 7/12, and activity index was very low. So despite that, you have treated the child, and the child was doing very well. What was the renal function at presentation? Is it normal or?
No, I presented. She had an eGFR of 58. So in children, even though they may have a high chronicity, if they have some activity, we will try top level immunosuppression. We were veering to go for cyclophosphamide, but because of the significant damage, we chose mycophenolate for this patient. And we've been seeing her jointly with pediatric nephrology 7 years on, and her eGFR is now 78. Child has grown about 15 centimeters, and she's doing well, attending full-time school.
That's right. That was my second question. You have started on MMF, but actually renal function is there. So cyclophosphamide would be better choice. And when you use rituximab in your patient, when you call the patient resistant lupus with the first line of treatment.
Okay, so the current recommendations that we use come from the American College of Rheumatology and from the European guidelines called SHARE. Currently, the recommendations which were written about 4-5 years ago state that you use either IV cyclophosphamide or rituximab. There is no superiority of either of the two, but there are some situations where one would prefer cyclophosphamide. For example, the patient has a DAH. The patient has an organic brain syndrome. The patient has got severe CNS lupus. So when you want a broad, quick, rapid action, we would use IV cyclophosphamide. Or if we have adverse prognostic features in the child, such as severe hypertension, cellular crescents, and a very low complement, severe hemolytic anemia, we would use CYC. Now, your question about when to use rituximab, the two guidelines state that if either of the two agents does not work for induction, at 3 months, if the patient is worsening, you will switch the agent, or if the patient has not gone to remission at 6 months, you will switch the agent. And the role of rituximab comes after switching, as per the guidelines. But in our practice, if we induce the child, for example, with cyclophosphamide, and the child has not responded well, we would often give rituximab and then switch the agent. And I can't recommend that because that is not coming from any of the authorities.
Do you have any experience with belimumab?
It's not available in India. We have no experience.
Thank you, ma'am. One question from my side. In case of aortic arthritis, so when you decide whether to immunosuppress them or not, whether you look for disease activity in such patients before
Yes,
putting
there
them on
are-
immunosuppression?
Yes, there are scores. They are called the ITAS, where you look at the aortoarthritis scoring, and we look at the MR angiograph for this patient, because the MR angiography is going to show us not only the site of disease, but it is also going to show us the thickness of the vessel wall. So when we have an initial encounter with the patient, and the patient is either febrile or has acute phase responses or has significant lesions, we will always immunosuppress. And then as we follow on these patients, we will adjust the immunosuppression depending upon what the imaging is showing and what are the clinical features on the patient. A current recommendation is to repeat angiographic study annually. So if we see new lesions or we see continued inflammation, we would continue immunosuppression.
Whether you go for biopsy in such patient, ma'am? Whether you do biopsy?
No.
Usually angiography, you look for a repeat
Yeah,
angiography.
the recommendation is angiographic study. And the other thing that angiographic study is very important for is to pick up the mimic of aortoarthritis, which is IgG4. Because of those patients have got perilesional inflammation in addition to the wall.
Professor Georgie, please.
Thank you for that excellent presentation. I just want to tell you a case report. 1996, I had a young girl with lupus, school student presented with involvement of the kidney. So initially we used steroids, and now she's on maintenance with azathioprine, doing excellently well. Do we have to use cyclophosphamide and all these things for in the maintenance phase? Because every patient teaches you a lesson. Azathioprine, she got married, she didn't want to get pregnant, so she continues from 1996 to 2023 with low dose azathioprine with an ANA positive and 5 milligram steroids. So I'm just suggesting that do we have to follow blindly what the Americans and the Europeans say in our practice?
Thank you for that excellent question. So the current paradigm of management of the child with lupus is to treat the patient in 2 phases, where it's much like oncology today, where you first want to put out the fire by using an induction agent, and then you want to make sure that the fire doesn't come back again by using a maintenance. The current recommendation is to use either MMF or cyclophosphamide. In our practice, we have reduced the use of cyclophosphamide tremendously. And mycophenolate is as safe, if not equally safe, comparing it to azathioprine. And just to bring to your notice, sir, that amongst all the immunosuppressants we use, azathioprine, unfortunately, has a fairly high risk of giving the patient a new mitotic lesion. And the question also is that when we are using maintenance therapy on these patients, how long do we use it for? The current recommendation is minimum 5 years. but perhaps much longer. And I totally agree with you. You may have an occasional patient who may do very well on Azoran, but unfortunately, you cannot tease out that patient from a whole group, and therefore it's difficult to recommend this for all patients.
Dr. D.K. Pahani sir wanted to make a comment, please.
Yeah, so I agree with you. I think we started on the kidney transplant in 90s with the azathioprine and steroid. So the problem is this azathioprine, if you continue, the viral words and the malignancy is higher than the what we are seeing today without azathioprine. I agree with you.
Thank you.
Dr. Rajiv, please.
Yeah, so Sujata, thank you. I think the adult world, at least in the Western, they are coming out from cyclophosphamide and going to MMF. And latest series from the European also, including the UK juvenile cohort, SLE cohort, they are also showing that even in pediatric, MMF is as good as cyclophosphamide in most of the situations. So I think one of the message maybe that should go out is that in most of the situation of SLE nephritis, I don't know about the other SLE nephritis, first drug of choice can still be MMF, unless until, as you correctly said, that we are worried about the very high severity, like a CNS or a creatinine very high. But in most of the other situations, we have also found, and we are in the process, we have just submitted it to lupus with fingers crossed that our cohort, it was a cohort of 60 children that we saw in the last 10 years. And most of them, we used MMF, and overall there was a good outcome.
So thank you for that comment. There are a lot of issues with using MMF for every child. We are unable to give the mycophenolic acid drug levels in India. We know that there are racial and ethnic differences in the way the children tolerate mycophenolate. And a very big issue is adherence for the child who's a teenager. So we have to take everything into context before we decide which drug for which child.
So last question, Dr. Dave.
Excellent presentation, ma'am. Do you think in aortoarthritis, Takayasu PAT-based imaging has better role than MR and plain CT angio or MR?
So the issue with the PET imaging is that how do you follow up these patients? We know that the risk of a malignancy with radiation is inversely proportional to the age of the child. So though PET may help us when we are hunting in the dark, for example, for a persistent pyrexia, it does not have any role in the follow-up. Now you want to compare apples with apples, and therefore it's nice to get a MR angiography initially and then follow it up with the same modality. The difficulty with PET is that once you have the answer, how do you go ahead and follow? In our center, it's a serendipitous pickup when we are getting a PET done, for example, looking for a malignancy, and we by chance pick up an aortoarthritis. But specifically for aortoarthritis, we are not very often ordering the PET.
So thank you, ma'am. Thank you for presenting interesting cases. And there's no more questions, so I declare the session to be closed.
Thank you so
very
much. Thank you.
So speaker and all chairpersons are invited for the memento presentation and a group photographs. Thank you. Continuing the journey of nephrology and rheumatology, the next session is on lupus nephritis in children. So this will be presented by Dr. Manish Rathi, and to chair the session, I invite Dr. D.K. Pahari sir. He is Senior Consultant, Department of Nephrology, Medica Super Speciality, Kolkata. Dr. D.K. Pahari sir. I invite Dr. U.S. Rai, who is ex-HOD, Department of Nephrology, IGIMS, to co-chair the session. Dr. Shashi Kumar, Department of Nephrology, Paras HMRI, Patna. And Next chairperson are Dr. Jamshed Anwar. He is consultant nephrologist at Ruban Memorial Hospital, Patna. Over to chairpersons.
Good morning, ladies and gentlemen. We welcome you all in the second session of today. Topic is nephritis in the children. As we know that it is less common if you compare with the adult, and is very uncommon below the 10 years. But if it happens, takes a very severe form. Mortality and morbidity is very high. Many aspects of this children in the SLE already we have listened by Dr. Sujata. The rest will be discussed by Dr. Manish Rathi. Dr. Rathi is Associate Professor of Nephrology in PGIMR, Chandigarh. May I request Dr. Rathi to start the talk, please?
Thank you, Dr. Rai. And at the outset, my thanks and gratitude to Professor Hemant, Professor Om, Dr. Amresh, and entire organizing team for inviting me here to this wonderful city of Patna. And I also like to thank Dr. Sujata. She has taken most of the questions and she has made my job very, very easy and answered all the tough questions already. So I hope that you will not be left with any more questions at the end of my talk. So the talk is managing lupus nephritis, and are kids any different? So what we call as childhood lupus nephritis or juvenile onset lupus nephritis is when we have onset of disease before 18 years of age, and the peak incidence has been reported to around 12 years. 15 to 20% of all lupus patients are said to have onset in the pediatric age group as per the registry data. The incidence is 0.3 to 3 per 1 lakh population, and prevalence is about 2 to 34 per 100,000 population. What is important to note is that there is less female preponderance in childhood onset. That is, more male patients are likely to get affected by lupus and lupus nephritis in childhood age. So the female to male ratio is 4:1 or 2 up to 4:3. This childhood onset disease is more aggressive with a higher disease activity. There is high incidence of renal involvement particularly, and renal involvement has been shown to occur as high as up to 80% of the cases, and most of these occurrences occur within first 2 years. And as like adult lupus, African Americans and blacks have more severe disease activity as compared to Caucasians. 10% of these patients will progress to CKD stage 5 despite best of your therapy within first 10 years. So we have to be careful about that. And the standardized mortality rate is also almost 3 times in childhood lupus and lupus nephritis as compared to non-lupus patients. Now, pathogenesis is similar in childhood and adult. Only difference what has been reported is what is the role of genetic, because we know that lupus is a complex disease. There is complex interaction between gene as well as epigenetics and other phenomena. But in childhood onset, what has been reported is that many cases are monogenic in origin, and 7 to 8% of all children as compared to 1 to 2% of adulthood will have monogenic disease. There are more likelihood of affection of siblings. If one sibling is already having lupus or lupus nephritis, there are higher chances of other sibling being affected, and the concordance rate is also among monozygotic twins have been reported to approximately to be 40%. So this is difference in the pathogenesis between adult and childhood. Now we all know that EULAR ACR criteria have come up in 2019 and 2020 as a classification criteria, and they have replaced previous ACR and SLIC criteria. But how does these criteria perform in childhood onset of lupus nephritis? And this was a comparison between 3 criteria of ACR 1997, SLIC, and ACR EULAR in childhood onset lupus nephritis. And what they have shown is that they are more sensitive but less specific. So we may be picking up non-specific cases if we are using these criteria in childhood. And what has been proposed, and it has to be validated, that rather than cutoff of 10, which we keep in adult patient, we should be keeping a cutoff of 13 for EULAR ACR criteria if we are implementing these in childhood lupus patients. And other things like disease activity mark indices like SLEDI, SLE responder index, BILAG, and SLIC ACR disease activity damage index, they all have been validated in childhood lupus also. So you can very well use these indices. And then also there are certain health quality questionnaires which have been validated in childhood lupus. And if you are keeping these patients on a longer follow-up, especially in registry data, these are the scoring systems or indices which you can use. Now, what are the differences between clinical manifestation of childhood and adult? As I have said earlier, they are more aggressive and there are more chances of having renal involvement. There are higher chances of having cardiovascular involvement and higher chances of having neurological involvement. And also this was a big comparison of more than 10,000 of where around 2,000 were childhood and remaining were adult, and they have compared clinical features, and this has been reciprocated in this article. And also what they have reported is that the hematological manifestations are also more common in childhood onset lupus. If we talk about lupus nephritis and what is the distribution of class of lupus nephritis, there are various publications from India as well as from abroad that class 4 with or without class 5 is the most common class of lupus nephritis, affecting as high as 50 to 60% of cases, and remaining are class 3 and class 5. So just like adult, they are having a similar distribution of lupus nephritis. Now coming to management. So management, some of important aspects have already been covered by Dr. Sujata. So it is a multidisciplinary approach. It should include pediatric rheumatologists and nephrologists. It should also include, because there are, and I'm going to show you what other aspects of important management issues are there in childhood lupus nephritis. So we should also involve psychologists, nutritionists, physiotherapists, social workers, and other people. There are certain general things which you should be advising to all childhood lupus patients, like use of sunscreen, very, very important, which we often ignore in our busy clinical practice, because when the flare occurs, it almost always starts from skin. So they have to use sunscreen 2 to 3 times a day. They should have a well-balanced diet, salt restriction, control of hypertension, regular physical exercise. Immunization we will talk about in detail. There should be counseling regarding drug adherence and psychosocial support. Now, Dr. Sujata has said about American College of Rheumatology, but the similar recommendation is by KDIGO also, that the management of childhood lupus nephritis is in a similar manner as you will be treating an adult patient with a special consideration to certain area, which we'll be discussing about. So if you are dealing with class 1 or 2 lupus nephritis, so if unless there is a significant proteinuria, you will not be giving them any steroids. You just be managing them as like use of ACE inhibitor, ARBs along with HCQS. However, if they have significant proteinuria, you can try giving them glucocorticoids, and if they are not responding, you can give them immunosuppressive therapy. Now, class 3 and 4, which are proliferative lupus nephritis, there are 2 guidelines which are specific to pediatrics, and these are CARA guidelines and SHARE guidelines, and both of these have not specifically mentioned one regimen over other. So what they have said is that you can use monthly cyclophosphamide regimen, you can use 15 days, that is urolupus nephritis regimen, and you can use mycophenolate mofetil. And these are the doses. Like if you are using monthly, you start with 500 milligram per meter square, and you can go up to 750 milligram per meter square. And if you are using mycophenolate mofetil, then the dose is about 1200 milligram per meter square, and maximum dose which has been recommended is 2 to 3 grams. And this is a wonderful review article which has been published by Dr. Arvind Bagga's group just last month. And what they have summarized kind of what are the guideline recommendation and what is the practice recommendation. And what they have come up is that if you are dealing with class 3-4 lupus nephritis, initial methylprednisolone pulse followed by oral steroids, and then you decide depending on what is your preference and what is patient preference, you start with either cyclophosphamide or mycophenolate mofetil, and then you assess at the end of 3 months. Now they have said that if patient is not responding, and this is what Dr. Sujata has also said, that if the patient is not responding at the end of 3 months, they have to be switched to alternative regimen. I think that is difference between adult and childhood. We don't switch to regimen unless they are worsening. In adult lupus nephritis, we only switch regimen if they are worsening. But in this flow, they have said that if they are refractory within first 3 months, you may be switching this therapy. So you can switch if they have received cyclophosphamide, you can switch to mycophenolate mofetil and vice versa. And at the end of 6 months, then you try alternative regimens like use of cyclosporin or tacrolimus or addition of rituximab. I think what other thing was difference is that these patients are maintained according to this flow. The maintenance dose of steroid, what they have mentioned is 7.5 to 10 milligram, which I think is little bit high. We can maintain them on 5 to 7.5 milligram, which is what guidelines have also said to reduce the toxicity of glucocorticoids. And this was a meta-analysis like what are the differences between various kind of induction and maintenance regimen. And what they have shown is that both the regimens, whether you are using mycophenolate mofetil or you are using cyclophosphamide, they work equally well in childhood lupus nephritis. And so you decide according to the patient severity of the disease, preference of the patient after discussing with them, as well as your preference. Coming to rituximab, a nice case series by Dr. Sujata, where they have used rituximab in childhood lupus nephritis. So there was a cohort of 225 patients, and 17 of them were given rituximab. So there is data that rituximab can be safely used in childhood lupus nephritis with a relatively good outcome. But again, these are to be used only if they are not responding to your first or second line of therapy. That is cyclophosphamide and mycophenolate mofetil. And these are other reports of use of rituximab. There are various reports. So patient number varying from 11 to 50 almost, and they have used rituximab for variety of indications, and they have shown good outcomes with rituximab. There was a question regarding belimumab. Can belimumab be used in childhood lupus? Certainly it can be used, and there was a randomized trial which was known as Pluto, which was specifically for pediatric lupus. And what they have shown, and they have compared it with the Bliss trial, Bliss 52 and Bliss 76, is that the response in childhood lupus with belimumab is as good as in adults. So the SLE responder index at week 52 was significantly reduced as compared to placebo. This was over and above your standard of care, that is mycophenolate mofetil, as well as at the end of the SRI-6 at the end of 52 weeks was also better, and they reduced the chances of flare. So belimumab can again be safely used in childhood lupus nephritis. SCQS, very, very important. Don't forget all your lupus, irrespective of lupus nephritis or not, to put them on SCQS, a safe drug, effective drug to prevent future relapses. The dose is 5 to 6 milligram per kg per day. And what you should also remember is that you should be monitoring these patients for toxicity in terms of retinal toxicity, because it can be reversible in about 0.5 to 1% of cases. So what is recommended is that every 5 years you should be evaluating their retina for retinal toxicity, and SCQS is almost lifelong in these patients. What about glucocorticoids? Because these are childhood, they are growing people, they have bones which are growing. So there is significant steroid toxicity which occurs in childhood lupus. So it is seen more if the steroid dose is more than 7.5 to 10 milligram per day. And that is why I said that it is in the maintenance, you should be using about 5 to 7.5 and not more than that. And they also not only have effect on bone health, they also have effect on their gonadal system. And it has been shown that patients who have were on higher doses of steroid have more delayed puberty onset in childhood, both males as well as in females. And this was a very nice paper where they have compared childhood lupus versus adult lupus, and what was the steroid toxicity irrespective of the duration. So the duration was same. So you can see if the duration of steroid exposure is 0 to 10 years versus 11 to 20 years versus 21 to 50 years. So duration is important, but what is also important is in the same duration, the child will have more toxicity of steroid. So you can see this is adult and this is child. So every duration, the childhood exposure to glucocorticoids will have more toxicity as compared to adults. Now, if you have managed, what are the outcome results with childhood lupus and lupus nephritis? And again, this is the same narrative systematic review by Dr. Bagga's group published this month. And what they have shown is that the complete remission at the end of 1 year is about 60%. Partial remission is about 27%. So if you look at overall renal response at the end of 1 year, it is about 87%. And what is difference, and this has been noted in adults also, that in lower and middle income group, we have more complete remission as compared to partial remission as compared to Western. And this has been shown both in childhood as well as in adult studies, that complete remissions are more in developing countries rather than as compared to developed world. But what is surprising is that even if we have better complete remission rates, but our outcomes at longer term outcome like 10 years or 20 years are worse than what has been reported from West. And this is same kidney survival, same paper. Kidney survival was at the end of 5 years has been reported in the range of 80 to 90%. And this was what I was saying you, that our long-term outcome are inferior as compared to what has been reported from West, despite we having better complete remission rates in short term. And patient survival was also in the range of 80 to 90%. Most of the patients who die, and this is the mortality data, most of the patients who die, almost 50% of these patients die because of infection. And that is very good, important thing to remember. Then don't overtreat, don't be very, very aggressive with the immunosuppressive therapy, because you will be losing your patient to infection rather than disease activity. So 50% of patients die because of infection, and about 20% of these patients dies because of lupus activity. And these are other paper, and these are kind of follow-up. So up to 20 year of follow-up data is available from Western world. And this is similar, like what I have said earlier, that about 10% of these patients will progress to CKD stage 5 by the end of 10 years. And so the renal survival is about 80 to 90% at the end of 10 years. What about India? So this is a paper from SGPGI Lucknow, where they have followed about 200 patients. This was a retrospective analysis, childhood onset lupus for a long-term follow period of 13 years. And the biopsy series was similar, like majority of patients had class 4 lupus nephritis. And the data from SGPGI has also shown that about 7 to 8% of their patients progress to ESRD by the end of 10 years. And this is comparison of SGPGI study and other centers, including one from PGI Chandigarh, where what they have reported is that majority of, even in India, 50 to 60% will have class 4 lupus nephritis, and the 10-year survival, renal survival will be about 80 to 90%. What are predictors of poor renal and patient outcome are if you have more severe activity, if you have younger age of onset, more severe disease, like you have renal dysfunction at presentation or requirement of dialysis, you have class 4 or proliferative lupus nephritis, and you have flares, repeated flares. If you are having a long term, you will have a more severe outcome. What are other aspects of management? And these are very, very important if you are dealing with childhood onset lupus, lupus nephritis. You should not forget these other aspects of management. One is vaccination. So you can use, you should not be using live attenuated vaccine after you have started these patients on immunosuppressive therapy. So whatever, if time permits, if patient give you time, you complete your vaccination schedule before giving an immunosuppressive therapy. However, dead vaccines, non-live vaccines can certainly be used in childhood onset lupus nephritis, irrespective of whether these patients are on immunosuppressive therapy or not. Non-adherence is very, very important issue in childhood onset disease, and it has been reported to as high as 50 to 60% of cases of childhood will be non-compliant, and 97% of pediatric rheumatologists have reported they have encountered significant non-adherence in their practice. And this non-adherence actually affects the patient's self-esteem and self-management. And although people have advised that we should be using something like medication reminder, like in last web-based education and medication reminder, this improves their adherence. But what has also been reported that if you put this patient on these kind of reminders, they affect their mental health, because they will always be, having this, always be bugged by this continuous reminder. Although their adherence will be improved, but they will have significant low self-esteem. So mental illness, mental health is another important area which is neglected, and it has been reported that depression and anxiety can occur in up to 1/3 of patients. And so that is why when in the beginning I said it should be multidisciplinary approach, and it should also include your psychologists and psychotherapists, that these patients should be counseled regularly regarding what is their adherence, what is their mental issues, and scholastic performance and things like that. Another important area is bone health, because these patients are on long-term steroids and also on other immunosuppressive therapy, which will affect their bone health. What is recommended is that you should be doing an DEXA scan on these patients on a regular basis and try to improve their bone health by giving regular calcium supplementation and regular vitamin D supplementation, and try to keep vitamin D levels more than 50 nanomole or 20 nanograms. Gonadal health, another important area, especially if they have crossed the pubertal age. If they have achieved the puberty, gonadal issue come up, because gonadal dysfunction occurs in these patients, both in males as well as in females, and it can be permanent or irreversible in some proportion of cases. So what is recommended is that you should be ideally evaluating their hormonal profile as well as radiology, like especially in females, you can do their ultrasound pelvis, ovarian follicular count, and keep on monitoring these counts and what is happening on a long-term basis, so that you can pick up these cases on an early basis and manage them accordingly. There was a question whether we should be using GnRH. You can certainly use GnRH. You can certainly go for ovarian preservation and sperm preservation. But what is important is that it will not be of much use, especially GnRH, because if you are using GnRH, it has to be given at least 3 weeks prior to the giving of your first dose of endoxin. So in subsequent doses, it may be fine that you have time, but in the first dose, when you have to give immediate pulse of cyclophosphamide and you can't wait for 3 weeks, you can't be using this. So it's almost impractical to use. But certainly in subsequent doses, you can use this GnRH analog. And if the cost permits and patient is willing, you can go for ovum and sperm preservation. Now, another important neglected area is pregnancy, and we often ignore, and there are a lot of publications that these are adolescents age group, and they are sexually active, and mean age of first sexual intercourse was reported at 16. So they should be counseled regarding this. They should be advised for contraceptive if they are sexually active, and you should be avoiding unnecessary pregnancy, because pregnancy is going to affect their outcome, especially the long-term outcome. So again, a neglected area, but should be taken care of, especially if you are dealing with this adolescent kind of people. Similar to adults, like you should be avoid using cyclophosphamide and mycophenolate mofetil if they have already become pregnant. Cardiovascular health, because they are long-term patients, cardiovascular health is going to be affected. So 5 things you should be looking at, and you should do these 5 things on a regular basis on 1 to 2 year interval. That is hypertension, body mass index, diabetes mellitus, smoking, and serum lipid level. And there are a lot of safety data which is now available, that you can certainly use statins in your childhood patient if you want to control their lipids, and there is no long-term toxicity of statins with these in these patients. And finally, there is concern about malignancy, because they will be surviving for a long period of time. So there has been report that significantly, like 4.7 times higher incidence of invasive cancer and 5.2 higher times of hematological cancer. So a regular screening protocol for cancer should be devised if you are managing these patients on a long-term basis. And importantly, transition of care from childhood to adulthood, because this disease will continue to go on till adulthood. So transition of care, you should always be discussing these issues with your patient and their caregivers in detail, that now it will be transitioned from childhood care, like from pediatric rheumatologist or nephrologist to adult rheumatologist or nephrologist, because what has been reported that during this transition of care, many flares occur if you are not discussing properly with these patients. So a proper transition should be taken care of. Kidney transplantation can certainly be done. There are no pediatric specific outcome has been reported, but what we know from adults, that disease recurrence is very, very rare, less than 10%. The outcomes are as good as non-lupus nephritis patients. So kidney transplantation can be offered if these patients have reached CKD5D. So to conclude, childhood lupus, as I've said, is a chronic inflammatory disease, and it is a more aggressive disease. And these patients are a very long-term follow-up, unlike adult onset lupus disease. So it has an impact on holistic growth as well as development of child. So it should be treated. As far as immunosuppressive therapy is concerned, the treatment is similar to what has been recommended in adults by various guidelines, but very important, should be you should take care of other aspects of their care, like their bone health, their mental health, their non-adherence issue, their vaccination issue, their cardiovascular issues, and things like that. Don't forget about this, because this is a long-term disease. Chances of long-term complications are more, and that is why you should be screening them and managing them properly. Thank you for your patient hearing. Happy to take any question.
Thank you, Professor Rathi, for your exclusive and crispy presentation on childhood lupus. And in your talk, you cover almost all the topics related to childhood lupus. So there, I think there will be very less scope for any questions, but still, if there is any question or comments from our audience, it's open for any questions or comments. Mike, please.
Sometimes what happens is, because these patients are having fever and they'll be showing some lymphadenopathy in the chest X-ray or some retroperitoneal lymph nodes, they are started on ATT from outside. And once they come to us, we diagnose lupus. So what about this ATT that they are on for last 1 to 2 months? Should we continue it? Should we stop it and then start the pulse therapy? Because
So I think this is a very common thing. We also note that many of these patients will be receiving ATT because they will be misdiagnosed as tuberculosis. But once you have confirmed your diagnosis that this is lupus and there is no tuberculosis, I don't think there is any justification of continuing ATT in these cases. You stop ATT and give them therapy for lupus. But very common issue, I think, because of fever, unexplained fever, long-term fever, lymphadenopathy, and things like that, they will be put on ATT, but no justification of continuing it.
Yeah, excellent talk, Manish. My comment is regarding steroids. Is there any move towards steroid sparing protocols? That's the first part, because steroids are not innocuous drugs. And the relation between osteopenia is actually cumulative dose related rather than the maintenance dose. There are several papers, including ours in nephrotic syndrome, where we found a direct correlation with the total dose and the changes in bone density. So any move towards stoppage of steroids and moving?
So surely it is related with the cumulative dose, and that is why I have said that when you are using maintenance, don't use 7.5 to 10. It is not required. 5 to 7.5 is enough in maintenance. So that should be the dose. And steroid sparing, I think the world is moving towards rapid steroid tapering rather than steroid avoidance, in at least in lupus. There are steroid avoidance in ANCA. So rapid steroid tapering will be done if you are using certain newer kind of therapy, like voclosporin has been used with a very aggressive steroid tapering, and by the end of 4 weeks, these patients are on 2.5 milligrams of steroid. Similarly, with belimumab and other biologicals which are being studied, they are studied that they are not going to replace your current standard of care. You will continue to give your mycophenolate mofetil or endoxan, but what you are targeting is if we can aggressively reduce their steroid and just maintain them on 5 milligram or 7.5 milligram.
Related to this lymphadenopathy and SLE, many times I have seen the patients which have been misdiagnosed. Sometimes a patient has Kichuki disease that comes in, and sometimes that have the similar necrotizing lymphadenitis, and that requires attention. And many times we used to treat this patient like SLE, go on treating. So we should have one differential diagnosis in the mind at that point of time.
Yes, thank you.
If I could make a comment. So I think that one very important thing is in the SHARE guidelines and even in the ACR guidelines, the initial dose of steroid has certainly come down. Earlier, we were using 2 milligram, but now it's 0.6 to 1 milligram. There is a lot of work done in the UK about steroid sparing regime, which was done in adults by the Eisenberg group, where they use rituximab with IV steroid and mycophenolate with no steroid in between. And they gave this regularly every 6 months, but that group of patients had a very high risk of relapse. So we're not currently using that in pediatrics. I think a couple of more interesting things from a pediatric standpoint is, first of all, we need to monitor the growth velocity of these children. And this is one condition where growth hormone is relatively contraindicated. So we don't like to use growth hormone because the lupus can flare up very significantly. Secondly, I think it's very important and something we don't do in our practice as much as we should is screening lumbar lateral x-rays for these children, because many of them have silent vertebral collapse fractures. And then that group of patients, we can give alendronate. I'd like you to touch upon antihypertensives, which we've not discussed in these patients. What is your go-to drug other than the ACE inhibitor? Do you use combination inhibitors and ARBs in your practice?
Okay, thank you for your very nice comments. I think the rituximab data which you were talking was rituxi-loop and rituxi-rescue trials, which was done by Liz Lightstone. They have not been replicated anywhere else, and that is why nobody is using rituximab with steroid sparing. As I've said earlier, it is steroid tapering, which is, and you have also said that, and guidelines have also now brought it down to 0.8 to 1 mg per kg of dose rather than initial higher doses. So what is recommended is you bring it down. Regarding lateral x-ray, I'm not aware of that, but what has been recommended by guidelines is to do a DEXA on a regular basis, 3 to 6 monthly, and not do an x-ray, because if you do a DEXA, you will pick their bone health deterioration earlier as compared to their certainly every time we recommend these kind of thing, we are adding to the cost of the management. So that is if your cost is permitting. Regarding your question on antihypertensive, I think the drug of choice is ACE inhibitor or ARB. There is no doubt about that. Combination of using of ACE inhibitor ARB is not recommended these days because there is no added advantage and there is worsening of hyperkalemia. So you should not be using this drug. If your blood pressure is not getting controlled on ACE inhibitor or ARB, despite you achieving maximum recommended dose, then you can start these patients on other antihypertensive therapy, which may include dihydropyridines. But not to forget, I don't know if there is any data of SGLT2 inhibitor, flozins in pediatric, specifically in pediatric lupus nephritis. But in adults, at least we have now started using flozins in nephrotic or in proteinuria kind of patients whose blood pressure is not getting controlled, because they will reduce their blood pressure as well as they will reduce their proteinuria. And especially in lupus also, we have now started a project where we are randomizing them to flozins versus no flozins, because as of now, there is no data on lupus, whether flozins should be used. But SGLT2 inhibitor is another important group of drug, which will reduce their proteinuria as well as their hypertension.
Regarding lupus nephritis. So when exactly do you label lupus refractory? Because I'm not aware of any consensus definition to label a case as refractory. And second, in such cases, should we consider plasma exchanges before considering retux or something? If it has been already labeled refractory, especially in low resource setting where patients cannot afford rituximab.
So certainly there is no consensus definition of refractory lupus nephritis, and to confuse more, there is term which is known as non-responding lupus nephritis. So what is difference between two? So if you have used your first line therapy, say for example, you have started this patient on mycophenolate mofetil, you have waited for 6 months, patient is not responding, you label this patient as non-responder. You don't call them refractory. After you become non-responder, you switch them to another first line therapy. So if you have started with endoxin, switch them to MMF. Wait for another 6 months, so total 1 year. If they have not responded even to cyclophosphamide and MMF, then you call them refractory. This is consensus definition. This is not by evidence-based recommendation. So this is how we define non-responder and refractory. And at the end of 1 year, if you have labeled them refractory, then you can start using calcineurin inhibitors and things like that, or rituximab. Plasmapheresis is of no value unless there is associated thrombotic microangiopathy or APS or APS nephropathy. Other than that, just in lupus nephritis, it is of no value.
Thank you.
If there is no more question, thank you, Manish, for a wonderful lecture. I think we have enlightened all of us. Thank you very much. We close the session.
I request all chairpersons and speaker for the memento presentation. So our next topic is C3 glomerulopathy, current understanding and management. To chair the session, I invite Dr. Umila Anand. She is senior consultant nephrologist and head of department at Amrita Hospitals, Faridabad, Delhi, NCR. I invite our next chairperson, Dr. Pankaj Hans. He is head and head of Department of Nephrology and Kidney Transplantation at Ruben Memorial Hospital and associate professor, Department of Medicine, Patna Medical College and Hospital. I invite Dr. Mrityunjay Kumar, who is assistant professor, Department of Pediatrics at AIIMS, Raebareli. And Dr. Abhishek Raman, he is associate consultant nephrologist at Jayaprabha Medanta Hospital, Patna. And I hand over the session to chairpersons for the next proceedings.
Good morning, everyone. Actually, Professor K.L. Gupta sir needs no introduction. He has been the former head of department of nephrology at PGIMER Chandigarh, and he has held several posts in the Society of Nephrology, like past president of ISN and ISOT. So without wasting any time, I hand over mic to Dr. Urmila for introducing the topic.
Professor K.L. Gupta will be talking on C3 glomerulopathy. I think this is an emerging area of interest for not just adult nephrologists, but for pediatric nephrology. And I'm sure, as Dr. Pankaj Hans says, that we don't need any introduction of Dr. Gupta, and let's go ahead and listen to him.
Thank you, Chairpersons. First of all, it's my pleasant duty to thank Dr. Hemant and his colleagues, Dr. Om, Dr. Shashi, Ramesh Krishna, and others for hosting this meeting and inviting me. I would just like to take an opportunity to say that 6 months back, when I visited an ISN assignment, I was told that such a meeting is coming, and I never imagined that this meeting was going to be such large and such a great academic and social event. Since yesterday, I have been enjoying every talk. Anyhow, I come to my assigned duty of discussing C3 glomerulopathy. As you know, C3 glomerulopathy is defined as a form of glomerulonephritis. It's a rather a rare disease wherein we have proliferative glomerulonephritis with C3 dominant deposition of the order of 2 or greater magnitude as compared with other immunorectants. Basically, this disease is interesting from the point of view that it is associated with a very high incidence of renal failure, and it's difficult to treat. And if you do transplant, the recurrence also is very common. Now, what are the questions that we need to answer? Is the C3 a new disease or a new terminology of an old definition? What is the role of complement in health and disease? What are the pathological spectrum of C3 glomerulopathy, and what are clinical manifestations, how to evaluate and treat the disease, and what are the problems in transplant patients? Basically, this disease has been derived from the old, what we call membranoproliferative. If you see here, membranoproliferative has to be understood in the context whether patient has immune complexes along with C3 glomerulopathy. In that case, we have this is immune complex mediated MPGN, which can be polyclonal or monoclonal, and we can be secondary to infection, can be autoimmune, or can be related to paraproteinemias. On the other side, if you have only C3 deposition, no immune deposits, then it's C3 complement mediated disease, and there are 2 diseases in that is dense deposit disease and C3 glomerulopathy. So these are related because are caused by alternate pathway of complement activation, dysregulation, and that's so. Here we see that under the umbrella of C3 glomerulopathy, we have dense deposit disease and C3GN. And if I just take you to old definition of MPGN, there are three. Burkholder had defined in three types: MPGN type 1, where we had subepithelial deposits and mesangial proliferation, and then type 2, where we have intramembranous deposits. We used to call ribbon-like pattern. If you see on the electron microscopy, and that's called dense deposit disease. And type 3 was when we had subepithelial, subendothelial, and sometimes epimembrane deposits. So what is C3 glomerulopathy now is dense deposit, that is type 2 is dense deposit disease, and type 1 and type 3 may be representing C3 glomerulopathy, glomerulonephritis. So this is what I already said that. And if you look at on the basis of immunofluorescence and deposits, MPGN has immunofluorescence positive, has immunoglobulin deposits, and of course, and dense deposit only has immunofluorescence positive C3 as well as deposits. C3GN only has immune deposits. Sorry, not this, only C3 deposition. And this is another picture showing you on the left side, it is MPGN type 1 and the type 2. And this is the morphological picture of mesangial proliferation and then membranous proliferative with double tracking and the immunofluorescence here. There was a very good paper which came recognized first time the primary glomerulopathy with the C3 deposition in 2007, wherein they described this entity. And out of 19 patients, 7 had association with C3 nephritic factor and 3 had with the complement factor H, 1 had with I, and other with membrane cofactor proteins. So that was the first time they described. And what is the epidemiology of C3? It has been estimated that there's an incidence of 1 to 2 per million population and 2 to 3 per million population prevalence. And as regard the relativity, some studies have described that dense deposit tends to be more common than C3GN. As for the age of onset, dense deposit disease occurs earlier in the younger people, and C3 is in the later age group. Gender-wise, there is no difference. Geographic distribution, not much, but particularly complement factor H-related nephropathy has been found to be in Greek seprites. Coming to pathogenesis, basically this is a disease wherein we have C3 deposition, and it is secondary to dysregulation of alternate complaint pathway. And this occurs because of increased activation of C3 convertase and decreased regulation of the C3 convertase because of functional, decreased functional activity of factor H and factor I. So here we look at this this diagram. Pointer, sir. So if you see here, I'll try this thing. We have three pathways of activation. We have got classical pathway, wherein we have complement factor 1, 4, and 2. And here we have the degradation products coming here, and then lectin pathway, they combine to form, what was C3 convertase, wherein we have got complement factor 4B and 2A. Then that further converts C3 and C3A and 4, another further dose, this is called C5 convertase. Similarly, on the alternate pathway, we have factor B and factor D, which act in presence of bacteria and viruses. They will activate, split 3 into 3A and 3B, and this 3B will be converted into C3 convertase. And this C3 convertase further splits C3, the cleaves further, and then leads to more addition of C3b to the C5 convertase. C3 convertase lead to C5 convertase. Now, what are the controlling factors? There are controlling factors are factor H and factor I, as far as the C3 and C5 are concerned. And there are more, we have membrane cofactor proteins, that is MCP, and then we have got complement regulator protein and decay delay acceleration factors. Again, same thing, how the dysregulation occurs. The important steps shown here are the C3 convertase formation, C5 convertase formation, and activation of C5 into A and B, and that's a very strong immunofilament marker. And this leads to formation of membrane attack complex C5b to 9. So, and there is further joining by the cytolytic actions, neutrophils, and things like this initiate the inflammatory cascade. Now, what are the main problems in this? Is what happens? Basically, there is a increase C3, and this is further helped by participation by Properdine and others, and there's decreased controlling action by factor H and factor I and membrane cofactor. And here, as we see, C3 convertase is the main thing, but crucial factor which plays the role. And so what are the regulatory proteins? We have got those which regulate the complement in the form of complement factor F, complement factor H, complement factor I, and then of course the membrane cofactor proteins, as mentioned here. I just highlighted these because I'm discussing this in context of therapeutics. There's complement regulator 1, and then we have got membrane cofactor protein and decay accelerating factor. So this is in pictorial demonstration of how the complement regulators act in the fluid and on the cell surface. Then these are the different antibodies I discussed in context of complement regulators and autoantibodies. So what are the causes of these? Why these alterations occur? There are genetic causes, there are acquired causes. Genetic causes is because of loss of function, because there is a decreased decreased production of factor H and factor I, and then similarly gain in function, more of C3 convertase action is there, and acquired factor can be mutations in these different proteins. Coming to pathology of C3 glomerulopathy, it can present in different patterns as shown here: mesangial proliferation, membranoproliferative, as well as diffuse proliferative. And correspondingly, we have got these immunofluorescence seen here, C3 deposition. Coming to dense deposit disease, it basically occurs in younger children, but can occur in some adults. And it is different patterns on histopathology can be membranoproliferative, where we have mesangial proliferation and then double tram track appearing of the basal membrane. You got thickened membrane is there, and then you got mesangial-proliferative, diffuse proliferative glomerulonephritis, and crescentic glomerulonephritis. These are different definitions here. And then, what are the features in C3 glomerulopathy? Again, this occurs little older children and the adults. Mean age is 30 years. There's no difference in male and females, and of course, the presentation can be with the as shown here, nephrotic, with hypertension, with proteinuria. And just to say, these are different histological patterns that you can see again through repeat, mesangial proliferative and membranoproliferative and crescentic, and this immunofluorescence. And the important thing to show on electron microscopy, this dense deposit is, if you see here, this cerebral-like deposits intramembranous, and then C3GN, this is subepithelial and subendothelial deposits. The clinical presentation of this is can be with there's some differences. This dense deposits are present more often with the nephrotic syndrome. C3 nephropathy, C3 glomerulopathy are more often present with the hypertension, renal failure, and as for the lab parameters are concerned, we have got alterations in the C3 decrease in both the cases. It is 100% in dense deposit disease and 48% in the C3 glomerulopathy. C3 nephrotic factor is very commonly associated with the dense deposit disease, and of course hypertension and proteinuria can be seen in both the cases. Renal failure again, both the cases. 50% loss of renal failure as well recurrence in both the cases there. And these are the tables showing the differences. This is just a repetition of what I said. Basically, the point is that C3 GN is little older and dense deposit is earlier. And if you see in the lab parameters, nephritic, the C3 nephritic factor is more often associated with the dense deposit disease. C3 convertase is more with the dense deposit disease. C5 convertase activity is more with C3 GN. And factor H related autoantibodies are in both cases. Soluble membrane attack complex is more often seen with C3 glomerulopathy. So these are extra renal manifestation. If you see on the left side, we have got drusen bodies in the retina, bush membrane. The deposits are there, and there will be acquired, partial lipodystrophy, Barraquer-Simon syndrome, loss of subcutaneous fat. These are associated more with dense deposit disease. Coming to another entity, just you should not forget about complement H factor related nephropathy. This has been seen mostly in Greeks of Cypriot origin. Incidence is 1:600. The important differentials are that this is associated with both microscopic as well as macroscopic hematuria, and it can occur whenever there is an episode of pharyngitis, and often it is not that much progressive as the renal failure is concerned. Sometimes glomerulopathy can be related with the polyclonal gammopathy, monoclonal gammopathy, as more of paraproteinemias, but this doesn't come here in discussion today with the children and kidney disease. It's more often, elderly people, if you have this thing, we should suspect this thing. Any CA3 in elderly age, we should rule out this thing. Coming to our Indian experience, we had a publication from Chandigarh. This was first time in 2007 to 2012. We had 31 patients. Again, dense deposit disease and C3 were there. They are younger as far as the dense deposit concerned, and 50% loss of renal function were there. Then this later in the study came, this was in 2020. Again, herein we have 115 patients, wherein we demonstrated again different patterns. And this is now 2022 unpublished data. Over the year, we have found more cases in PGI, and this is showing you the different patterns of presentation. These are different pathological patterns that we see in these people, and clinically, these patients, nephrotics are more common with the dense deposit disease, and nephritic nephrotic is both in both the cases, and nephritic with the hypertension is a C3GN. Workup of these cases, all this is shown here. C3, C4 levels need to be done, factor H, factor I, and we can even estimate other factors, C3 nephritic factors. Coming to the treatment of C3 glomerulopathy, well, first of all, we should evaluate what are we doing. If we encounter any patient with the microhematuria, with proteinuria, we always tend to think of either a primary or secondary nephrotic syndrome. And if we find that there are indicators, and we do all tests like ANA, ANCA, and all that. And then if on C3 is low, then we go further demonstration, whether obviously we'll do a kidney biopsy. And if kidney biopsy shows you changes of inflammation and the documentation is immunoglobulins and C3, we go in terms of immune complex mediated disease. If not, then we think in terms of C3 glomerulopathy, which could be dense deposit disease. And accordingly, if patient has immune complex mediated disease, then we'll go more for those immunosuppressive drugs, mycophenolate and cyclophosphamide. But if we find it is C3 deposition disease, then in the subsequent protocol I'll be telling you. And this is what we do in all the patients with C3 glomerulopathy, that there should be optimal control of blood pressure, and we should control their, obviously drugs of use are ACE and ARBs, and then we need to maintain their nutritional status, lipid control. And if there's a moderate, involvement in the terms of proteinuria more than 500 milligram, or the slight rise in the creatinine, we should think in steroids and mycophenolate. As for the different drugs which have been used in C3 glomerulopathy, There's a long list here. ACE and ARBs for hypertension, lipid-lowering drugs, and of course, immunosuppressive therapy with the steroids, both the standard oral and pulse, as well as mycophenolate, role of plasma exchange. I'll just touching on this. And most important, specific to C3 glomerulopathy are the role of anti-complement therapies, that is C5 in anti-C5 factor, and then other proteins which we were just discussing. So as for the KDIGO recommendations are that patient with mild disease, we just need to leave it. But if there's a patient with a moderate involvement with proteinuria of 0.5 to 2 gram, we need to treat with the steroids and mycophenolate. And since the basic mechanism of defect is the complement dysregulation, we should try to give anti-complement therapies as far as possible. So treatment of C3 glomerulopathy includes mycophenolate, and this is showing the benefit of this. In PGI Chandigarh also, we had a trial with 17 patients in whom we tried mycophenolate, and it's shown here. Can you help me? It's shown here. This patient with mycophenolate had a better outcome in the term of 65%. Coming to plasma therapy, there have been anecdotal reports of its utility in these people, and in our institute we had used it in terms of post-transplant recurrence, and these are the studies, but benefit was not much. Now coming to specifically to complement inhibitors, as we know the mechanism, just to revise classical lectin and alternate pathways. Herein we have C3 convertase and then C5 convertase, and important is the C5 complement factor H, complement factor I, factor D, and factor B, and property. So accordingly, we have got these diseases, whether we have got immune complex mediated C3GN, DD, dense deposit disease, and here are the drugs which are just touching on these later. Most important drugs that I need to discuss here is eculizumab. Most of the studies have shown its benefit because of its anti-C5a activity. And this drug is good if you use in early disease. Then it can have a better outcome. And some studies, of course, have shown that even in patients with advanced disease, it does reduce inflammation, and it helps in early reducing their renal failure development and delaying renal failure. The dose that to be given is 900 milligram IV weekly for 5 weeks, and then 1200 milligram every other week afterwards. So as against long-term beneficial, this just latest study in January 23, they had a study of for these patients. Basically, they found 14 patients they have reported. In 11, they had classical, they gave treatment, and in 3, they gave a standard of care. And here they found the beneficial effect in terms of stabilization of creatinine. That is, their GFR was maintained in the range of plus minus 30% in this percentage of cases, and in 6 cases, and in 5 it was a negative outcome, and 1 out of 3 in standard of care had a negative outcome. So they say there's a limited role. Then there are other studies which are like other future therapies, recombinant proteins as far as the anti-complement therapy is concerned. Then this soluble complement regulator 1 antibodies. This is another paper here. Then we have got factor D inhibitor, daricopan, and then this one comstatin, again a complement inhibitor, again has been studied. And then this is just a report which came last year. Constantin, this again factor B inhibitor. So these are different proteins which can be used. Coming to transplant, this is a very bad scene. I have personally seen so many patients. We did transplant. This member we believe 4 or 5 patients wherein outcome the recurrence was very fast, within period of 1 to 3 months, and their outcome has been poor. And this was a study from our institute wherein we had these number of patients, and uniformly we had a bad outcome. This list of the patients. So comparison of a PGI study with others, definitely our patients were younger and they had more severe presentation, outcome was worse. Coming finally to the end of my talk, this C3GN represents a form of nephritis wherein we have C3 deposition in the form of dense deposit disease, and C3GN, it's associated with the extrarenal features, especially in dense deposit disease. And we need to recognize this by early biopsy and demonstration of the specific C3 deposition on immunofluorescence, and treatment with the steroids and mycophenolate in moderate disease is okay, but use of complement factors also very important in patients with C3 disease, especially if used early. And of course, there are other treatments under trials. With this, I end here. Thank you.
Thank you, sir, for an excellent overview of a very difficult topic in our country, especially where we don't have anything much to evaluate and even treat. I just wanted to, because it's a pediatric audience and we believe and we see the common concern for us is to differentiate between a post-infectious glomerulonephritis and a C3G. So will you just elaborate how, and maybe we take opinions of pediatricians?
Very important, Dr. Urmila. This needs to be this very important differential diagnosis. Post-infectious nephritis, we can have C3. The thing is that in C3, they after 12 weeks, the complement level would come to normal in patients with the post-infectious nephritis, whereas it will persist to be low in patients with the complement, C3 deposition disease. And of course, there are other factors, other things you see morphological, and if electron microscopy, especially there, definitely that will differentiate.
Sir.
Any comments from pediatricians? No.
Yeah.
3 months titers of.
Actually, I completely agree with you. And as pediatric nephrologist, we many times confuse, and conventionally we don't biopsy in PIGN, but if it's a persistent IRGN, sometimes we biopsy, and many times we get DPGN picture on LM with a predominant C3 deposition on IF and without any predominant immune complexes. But in those cases, probably I think we can continue treatment with as a atypical PIGN. And many times we evaluate on the lines of other complements like CH50 and CF and other complements. I think ma'am will elaborate further how do you approach.
Overall, C3G is a bad disease, as you have also said that we don't have too many handles to how to manage them. But the clues to diagnosis, sometimes even at onset, if you have a very low C3, we know it's a C3G. I mean, you have a child presenting like a PIGN, but you have a C3 value of something like 6, 8, 10. You worry around C3G there. The second thing is like you tend to have patients presenting with more adverse presentations like crescentic glomerulonephritis, a bad renal failure right at presentation. But the other entity that you see is like patients presenting as nephrotic nephritic so-called presentations. And they are also very difficult situations, but we tend to biopsy them early on then. Yeah, we do always. Yeah.
In general pediatrics, we have so many patients coming with proteinuria, hematuria. In our general ward, in resource limited setting, how you will suspect the C3 glomerulopathy? Like in post-streptococcal glomerulonephritis, you have told about the complement returning to normal after 12 weeks. But other many patients of renal disease coming to general pediatrics with these symptoms, how we can suspect it for this, ruling out this?
I think if you're practicing, if you're a general physician or a pediatrician, any patient with proteinuria or hematuria, Of course, you would rightly suspect streptococcal and other infection-related disease, but you must consult a nephrologist. And if any time patient comes to me as a nephrologist, I would always do this complete profile of the complement profile, and particularly in female, little older, even ANA and other companies, all these parameters are important. If the elderly person, older person, I will send ANCA, and anti-GBM, all this. So immunology has a very important role. And these are the indicators that this is probably not a straight, simple post-traumatic nephritis. But then you have got other like ASO titers, are those are old things we don't do. But I think in every case we have to do complement and Dr.
Yeah.
Prasad.
We have no confusion if we have low C3 and after 8 weeks it becomes normal. So that is very clear. Problem is there with resolving PIGN. When PIGN is resolving, you do biopsy, you see only C3 is there, and many times normal C3 can be there in C3GN as well. So that is the most confusing point, where then you might have the nephrotic proteinuria, even electron microscopy, some epithelial humps can be seen in both. So that does not help all. So only thing is that if you show more signs of recovery, no response, then C3GN, if you have, because no clue as such that indicates that probably this is C3GN or this is resolving PIGN. So that kind of confusion continue on.
I don't think there is so much of confusion. It all depends person who's reporting. I mean, because in PGI we used to get very often the suggestion that to rule out C3, and especially if in centers, advanced center where the facility is electron microscopy there, then further all the doubts are taken up. Yes.
So I will take the lead when just Narayan left, the nephritic presentation and younger age group. Atypical PIGN not resolving, we do a repeat biopsy after 12 weeks. If the C3 is persistent, and we would, at that point of time, we take the hint that this persisting C3 and the typical picture of mesangial as well as sort of DPGN persisting, we call it C3GN.
Yes, we have been teaching our students that when you get a patient who is nephrotic, either younger or older, doesn't matter. But if you find, we normally don't do biopsies in state stop forward suspected case of PAGN. But if you find that over the time complement level is low, definitely, and persistent hematuria protein there, definitely you have to do a biopsy. Sir?
Yeah, right. Actually, if there is a nephrotic picture, you biopsy straight away. You pick up presentic changes and all that. You need to treat them aggressively, strongly right at the beginning. Do not wait for too long. If it's just typical like post-streptococcal, you might wait not too long. Important thing is to biopsy early on, the safe procedure.
Thank you.
Sir, in absence of eculizumab in our country, it is not available. For severe disease, what is your take-home message, sir?
What is it?
Eculizumab is not available in our country. So in severe cases of this C3GN, what is your take-home message? How to treat such patients?
In PGI, we tried all these things, steroids, cyclophosphamide, methylprednisolone, and I think ultimately, I have no answer to that question. We have to wait the time when we can afford the eculizumab come because the cheaper
Any
rate.
role of bortezomib in such cases?
Bortezomib, I don't know. I don't think it has been mentioned. That is an anti-B cell therapy. That doesn't come here. Anyone can say on bortezomib?
Professor Jha is
Okay.
You asked the question, what should we do if effective therapies are not available? So that is a bad scene, and one of our responsibilities as nephrology community is also to raise demand for making these therapies more available. The second thing is to let you all know that new trials are now entering development phase. So new phase 3 studies are coming our way, and I request rather urge all of you to enroll your patients on those trials. That is the only way they will have access to effective therapies.
enrollment of patients in clinical trial always raises the standard of care, no matter which arm of treatment they will go to. Even if they go to an arm, if mostly you don't know, because these will be randomized trials, and you might be blinded, or some cases you may not be blinded. But even if they go into the control arm, they will receive the best standard of care at that time, at least, even if they don't receive the study drug. So that is what we should do: raise demand, and second, participate more and more in clinical trials.
Before I leave, I would like to say, like the way we had experienced PGI, I mean, way back in 2014-15, we didn't talk about it. And after the studies came, then we started analyzing our old biopsies. So now what I want to say, all pathologists should be very, very keenly looking for this entity, and we might be, better helped in such cases if we are aware of such an entity there, and we do all these tests, and especially immunological test and evaluation in all patients with the presenting with the glomerular disease should be done.
Thank you, sir, for such an insightful talk. If there are no more questions, I would like to close this talk.
Thank you.
So our next session, sorry. Our next session will be a virtual one by Dr. Michael Molina. He is available with us on the virtual platform, and the topic is the changing paradigm of HUS, hemolytic uremic syndrome, the experience of UK HUS service. To chair this session, I request Dr. D.S. Baduria. He is Professor, Department of Nephrology and Renal Transplantation, SGPGIMS. To co-chair are Dr. Sukanya Govindan. She is Consultant Pediatric Nephrologist at Mehta Children's Hospital, Chennai, Apollo Children's Hospitals, Chennai. Next chairperson, Dr. Vijay Shankar. He is HOD, Department of Nephrology, NMCH, Patna. And another co-chair is Dr. Khushbu Rani. She is Consultant Nephrologist, Narayana Medical College and Hospital, Sasaram. Over to chairpersons to introduce our speaker and other proceedings. Thank you.
Yeah, good morning. First of all, I want to extend my thanks for inviting us. And it's my pleasure to introduce, can I have introductory slide? Dr. Michael Molina, who is going to talk about the changing paradigm of HUS. So it is a time to definitely, it's a very relevant topic, because it is really, there is a changing paradigm, especially in the field of HUS, especially in terms of finding new classification and etiology for the HUS. Dr. Molina is presently, he is working in RVT Great North Children's Hospital, NHS Trust, UK. So without much wasting the time, over to you, Dr. Molina.
Hello, thank you very much for the introduction. I hope the technology works and you can hear me. And I'm terribly sorry that I couldn't be with you in person due to some family circumstances. However, I am very glad that I can have this talk for you. I hope that you can see my next slide that says that HUS is fairly straightforward as it looks like to have the diagnosis. We can have from the description, we just need low platelets, hemolytic anemia, usually high LDH suggesting hemolysis, negative DAT or Coombs test, and high reticulocytes telling us that the bone marrow is working. And together with the kidney injury, together we have the syndrome, which is mostly a description of all the symptoms that we can have. To make it more interesting, it is not that simple. So at this moment, HUS, as we have it, is a part of a very big family of thrombotic microangiopathies. So ranging from the classical data that we have, and that's on the lower right side, that you have STEG-HUS. That was the first etiology descripted, and then everything that was not STEG-HUS, or as it was previously descripted with the prodrome of diarrhea as a D plus HUS. Everything that came after that was labeled as atypical HUS. So we can have all these that there are around. So with that, we now have a very broad differential diagnosis that we can go under thrombotic microangiopathies, and it is to find which one we can therapeutically approach. So definitely we can go with the infections, and we have now also the options to target some of the primary and secondary TMAs that looks like that there are. Now, more to that, there are overlaps also with the glomerular pathology like the C3G, as they are sharing some of the etiological background in complement. So with the pathology and the etiology, we know now that the atypical HUS, as we see, the main part is from complement dysregulation. So the first bit, what happens is that the patient is prone either through a genetic change in several genes like factor H, factor B, C3, or MCP, that they are prone to overregulation of complement. Complement gets dysregulated, it deposits on the endothelium gets damaged, and that's predominantly in the kidneys and small arterioles. Actually, we don't know why, which is a very interesting thing, probably due to very specific construction of the endothelium in these vessels. So we have the first phase when it gets dysregulated and endothelium gets damaged. The endothelium then attracts thrombocytes, which sit on the damaged endothelium and also attached to the subendothelial exposed tissue, create microthrombi, and these microthrombi that are then obstructing the organs. We are having an organ dysfunction in terms of kidney, the acute kidney injury, because there couldn't be a good blood flow. And these thrombi are creating a physical barrier that the red blood cells can't pass. And as they are pushed under pressure through this barrier, and they are getting damaged, resulting in what we see on the blood film as schistocytes or red blood cell fragments. The consumption of the thrombocytes can be quite massive, so we have the thrombocytopenia and the target organ damage, in this term, most of the kidney with AKI. Historical management was mostly very much supportive at that time. Firstly, there was not much of an insight what is causing the disease. Some of them were having low complement, some were not having low complements. So the staple of treatment at that time was plasma therapy, plasma exchange or plasma infusions that could have helped in some deficiencies of the complement proteins, or if there are factors that could be eliminated by plasma therapy. It was a very dire disease, and that was mostly all the patients diagnosed had a very high death rate. Usually in the first episode was up to 14%. When we were prognosing these patients and we were telling them what there will be their prognosis, 40% reached end stage in 5 years. There was a slight difference in certain groups based on the genetics, as you see on the table from an earlier review. And there was definitely experience of relapses, even in the milder one, like the MCP, that the recurrence was even up to 20%, or mostly like every few hours, every few years, the disease could relapse, it could remit, but slowly it reached into chronic kidney disease and end-stage kidney disease. So you see that this disease seemed like a very deadly and also having very high burden of morbidity. And this has changed quite rapidly with an advent of eculizumab, with the seminal papers showing effectiveness of this drug that was purposed originally for PNH and then extended its use because of clever thought that there is a complement dysfunction in these children. It nicely coalesced that the genetics found were also congruent with complement dysregulation, and these patients started treatment, and the treatment was very effective, as you see, prevented really much the end-stage kidney disease, stopped the relapse. At that point, the treatment was deemed that ideally it should be kept for life because the patients are having their genetic risks. So that was the first one, and I'm painfully aware that still, since that this earlier reports, early in 2000, the drug is not available globally, and I come to that slightly later also in my talk. This is the experience of our center, where we, this is cumulative data of the previous cohort in the red line on the Kaplan-Meier, and in the black line is the treated cohort of our patients after the eculizumab availability. So you see that this is very, in terms of reaching end-stage kidney disease, it is extremely effective. So you have the patients and reaching what was mostly the same numbers as in the review, or if they are on a treatment, they are having normal kidney function, and it is really rare that they would drop their kidney function. So this has put the disease completely on its head and changed it from a deadly and very high morbidity disease with bad prognosis, with an inability to transplant these patients, to a disease that it is not that very difficult to treat, but it had made it from a deadly disease to extremely costly disease. When I go back to the table of the TMAs, we have now cover for several of these. So definitely, and what is in our remit of our center is treating patients with factor-rich antibodies, some unexplained TMAs, some de novo, occasionally for pregnancy, and of course those ones that they are having complement gene mutations. The rest of the diseases is a slightly controversial topic because there are lots of reports of effectiveness in certain types of secondary TMAs, including hypertension and others. However, all the reports are skewed to by, I would say, probably mostly by reporting bias, that when you are having a patient that responds to the treatment, you are putting it into the body of literature. When you are not having that success, you are less convinced to put it, and it creates a slightly skewed view in the literature on the more positive side that this works, including the C3G, as it was also in the previous talk. In our experience, even in the early stages and with availability, it is not having much of a stellar outcome, and definitely also in the infection ones or those that are mimicked by sepsis, the treatment is definitely not to be recommended. So with that in mind, we have a treatment, but it is extremely costly. So what shall we do? In England, the decision was made that all the treatment should be passed through an expert center. So then became the advent of the National Renal Complement Therapeutics Center, which provides the diagnostics and also the treatment recommendations for England and recently also for Scotland. So we are having referrals from our colleagues in usually renal centers or on ITUs or PICUs, that they are referring us to patients and asking, could this be atypical HUS, and what shall we do with it? The service is quite highly regarded with this because, as we all know, the disease is fairly rare with a very low amount of patients that they are presenting. So you might be exposed to this disease in about once in a year, twice, or maybe even low. So you are trying to get the best diagnostics for your patients, and you are trying to then get the appropriate treatment. Because when it would be completely liberalized, you would think that in that big amount of patients that they can present with the similar symptoms, like it is, I've shown on the first slide, that you can label as HUS a lot of things. Why Newcastle was picked up as the center for this, there is a track record of quite achievements in research of atypical HUS and complement, where the first mutations were identified in Newcastle in back families from the south of England with identification of factor H changes, then progressing into further genes, the CFI, CD46, and also then the involvement of Professor Goodship in advent and the initial papers on eculizumab treatment. We are then broadening also the scope for investigating further genes and further involvement of causes and etiologies. And also we are gathering quite large body of data from all the referrals that we can differentiate based on genetics and complement profiles. I will just have a brief overview how our center works. So when we are having a suspected atypical HUS from anywhere in England, there is a referral that we hold a 24/7 service. There is six of us that are involved, definitely not on like a full-time basis. However, most of us are interested in this topic. So we gather over a virtual meeting, usually exchanging messages on a safe platform where we find and decide what is the initial decision, feed it back to the clinician, and drug is administered locally by the referring clinician if it is required. We also provide a courier service, so the samples are couriered to us very quickly, so we can do rapid tests for complement, excluding also TTP by measuring Adams 13 and for continuing with genetics. What we see also as very important is exclusion of STEC infections, that they are much more common than we thought, and that we can't differentiate definitely on the preceding symptoms like diarrhea. That was thought that it might be quite useful to see from our experience and from the data. It looks like that about 30% of genetically caused HUS are also presenting with some form of diarrhea or loose stool at the beginning. So it is quite useful to have an exclusion, because when you have someone who is having an STEC infection and you would start the treatment, you are not just treating the right thing, you are also quite wasteful in terms of resources, where a very simple PCR rectal swab or stool analysis can identify STEC, and we can exclude this patient from the treatment. This is the rate of referrals. So you'll see a heat map of where we are, mostly covering the large conurbations, but it is quite worldwide referral. They come to go quite rapidly. And since the start of the interim service, and then the service started in 2016, and you see that there is a steady influx of referrals, so you don't need to worry about not being busy. However, what we try and what we see as interesting is the orange line, that the treated cases are not that much increasing. So people are much more aware of atypical HUS. They are referring it. As you've seen, the diagnosis and the differentials could be quite broad. However, the true genetically caused and the treated cases are quite stable. So you can imagine if this gap would have been lower, then there will, and the amount of eculizumab that could be given might be much higher, which is also in some centers where it is not that, or in some countries where there is either no center or it is less strict with dispensation of the drug. So these are some numbers. These are the latest year. So we have been referred about 230 patients, recommended eculizumab initially in 38. Some of them were referred quite lately, so there was no renal recovery, or there was then later found a different pathology, and as 32 were treated in the year. And you can see that most of them were having some kind of complement mutation or change that, or factor H antibodies that made them prone to develop the disease. So we have now the treatment, and we have now a setup center. So what is next? Next thing that came was ravulizumab. So this is a second generation of eculizumab drug, that it is a C5 blocker on the level of complement in terminal pathway, and eculizumab is given every 2 weeks. And there was an idea: can we make it a little bit better? The company came up with slight changes, engineering small changes in the molecule itself, mostly switching few of the molecules and trying the new drug. There was a study in pediatric patients and also 2 bigger ones in adults, that all of them shown safety and long-term efficacy of this newly engineered ravulizumab as a second line of treatment. Why it is so interesting? Eculizumab is given every 2 weeks, and you can see how the antibody is recycled, mostly going into the endosome and lysosome, where it is targeted, and then it is taken out of the system. So it is regularly, it needs to have regular redosing. Ravulizumab, due to the small changes, is much more resilient in the body, much more resilient to not get destroyed in the lysosome, and because of the pH changes, it is then taken out and mostly recycled. So it stays in the body for up to 8 weeks, even more. When we have now stopped some patients, it looks like that stays in the body for very long periods, and the dosing is every 2 months. So that looks very good. The label would be, again, that patients should probably stay, that they are appropriate on the treatment for life. And then we are at the end of the road, it looks like. So we have a treatment, patients are fairly happy. There are not that many side effects, fortunately, of this treatment. There is a terrible, yet rare thing that they can have a meningococci infection, because as the complement is blocked, it is possible to have this. However, they are having a vaccine and they are covered with antibiotics for the duration of the treatment. So this chance that it is mostly about 500 times bigger than in the general population can be stopped. So is this the end of it? So we have for atypical HUS the treatment, and that's it. So our current approach looks like this. There is a diagnosis of possible HUS. We stop the treatment when there is an alternative explanation, like I've mentioned, STEC or other renal or hematological disease. We will have the genetic and factor H testing. We will see if some of those that they are not having a genetic change, or they are having a change that it is not responsive to eculizumab, like, for example, children and patients with DGKE, that they are not benefiting from eculizumab treatment, or if there is a futility after 6 months, you will stop. Otherwise, the treatment continues in these patients. Let's get to the elephant in the room, which is that the drug is extremely costly. And as I mentioned, it is not available, as you are painfully aware, worldwide. So is there a role for stopping eculizumab? There were several also attempts to prolong the intervals and do other things, how to rationalize the treatment. But it looks like that the original thought that eculizumab is for life is not the case. So why should we stop eculizumab? First, I have mentioned that there is certain risk that could be quite high in patients, there is about 500 or up to 2,000-fold increase in the risk of meningococcal disease for patients on eculizumab. So it is not without its risks. There is also an opinion of patients that we tell them that there is a limited, if you put it on its head, there is a limited evidence that the continued treatment is required for all patients. So they are asking these questions. There is the burden of treatment. Even now with the ravulizumab, it is much less than you need to have your infusion every 2 months instead of every 2 weeks. But surely, even for small children and the treble and all that could be slightly burdensome, not definitely to the extent that you need to go 3 times a week for dialysis for life. So this one of the bases, and then there is several rationale for stopping. One of the earliest was in a report from Italy, 10 cases that were successfully stopped without about 30% chance of recurrence of the disease. There is a very good led center in Holland, and in the Dutch experience, they are having a mandatory stop for most of the patients. So they are showing that even when they stop, the rate of recurrence is only in certain genetic traits, and also that it reaches about 30%. And the biggest cohort at this moment is from 2019 from the French experience, from the report from Fadi Fakuri, where they have stopped 38 patients. There were both children and adults. And again, the relapse rate was in about 12 patients. Mostly it was factor H variant, some in CD46. And those that they were not having any variant detected, there was no relapse. And that is also in our experience that we see if there is no genetics, it is very unlikely that the patients will relapse. However, even when stopping the treatment, and if there is a relapse, and if it is treated and identified early, there is not much of an late causes of increased risk to the kidney. So it looks like that it might be a possibility that even if the disease is triggered, it can be stopped fairly quickly in the beginning of its presentation as the patient is aware of it and the clinician, and the treatment restarted. We are also running a study in Newcastle in the same topic called SETS, or Stopping Eculizumab Treatment Safely, that I am PI for Newcastle and my colleagues are national leads. We are planning to withdraw 30 patients, and then there is also a smaller health economic arm for patients that they don't want to withdraw, but we are having it as a baseline. The patients after stopping are then followed for 24 months. We are now reaching end of observation period for most of the patients. That should end somewhere in November. And from the preliminary data, it looks like that they are mostly copying the part in France, that it looks like that it is safe to withdraw the treatment. And in certain patients, the relapse will be there, of course, but we were expecting that, and it is about how to make it safe. So the measurements are mostly to the safety of withdrawal and restart of the treatment without causing kidney deterioration or hematological changes or changes in other organs. And we have not seen that. And this is just for an illustration how the change can get into saving into real life, because even from stopping few of these patients, the treatment cost reduction goes to several million. So we are slightly revising our approach. We have a possible diagnosis of atypical HUS, and we can have an alternative explanation where we stop. We will treat with C5 blocking antibody eculizumab. We will do the genetic and stratification exclude those patients where there is futile or there is a the end stage kidney disease, because there was probably a later presentation in probably too much advanced disease. And we will see in those that they are having a minimal risk, that means that they are having no genetic change, we will likely stop treatment in these patients. And there is low in certain changes like CD46, we might try to stop it too, with an expectancy and very thorough discussion with the patient that there might be a relapse, but if we are vigilant for this, we can treat it again, and we can go into a cycle of not a continuous lifetime treatment, but mostly treating relapses. Then in a large could be fairly less common in most of the patients. Then there are those patients that would have probably a high risk of relapse. That would be factor H mutation, factor H hybrids, or patients that have been transplanted with a kidney transplant and where we don't want to risk even the slightest possibility that the transplant wouldn't be working. So they might be treated further and switched to ravulizumab as a long-term solution for these patients. Considering that there is not a global availability of eculizumab, one needs to work pragmatically. So I have also updated it slightly for how we can approach it with an unavailability. So eculizumab is available, and we can go to my previous label where we have those that we could stop, those that will need to continue. Eculizumab access is limited, so there needs to be default to either a plasma exchange or previous symptomatic care. The good thing is that from large cohort and reports from India that they are excellently covered for factor H antibodies are showing benefit of plasma exchange and treatment with additional immunosuppression to get rid of the antibodies and achieve remission even without the treatment with complement blocking agent. So at least for these patients, there is a chance. So in summary, eculizumab and also its second generation ravulizumab are an effective treatment for atypical HUS. The ideal approach is now to treat early, identify those patients that they benefit from the treatment, stratify based on an etiology, and thus mitigate the chance of long-term damage. Rapid control of disease manifestation that goes with the and re-manifestations. The conclusion is also that eculizumab shown from these 3 reports, and hopefully when we conclude our study, we think that it will show the same level of safety that eculizumab can be withdrawn. And this opens door also for, I would say, a more widespread use of it, because it is very hard to sell to someone. We are having an extremely costly drug, and we will need to treat it in a cumulative way for life. So that creates a tremendous burden. In a term of treating only the active parts of the presentation, it could be much more palatable. It looks like that less than 50%, it looked in the previous ones that they will not relapse at all, particularly those ones that are not carrying mutations. So then afterwards, it changes into close monitoring after withdrawal. And the final approach would be the move towards protocols based on intermittent treatment of acute relapses. With that in mind, it might be even that we are having new drugs that they are targeting complement on certain levels. So there might be even those that will not require infusions, and we'll see what the future will bring. Thank you very much for your attention.
Thank you, Dr. Melina, for that wonderful lecture, and also touching upon how the future of UK HUS service is going to look like. Our experience in India is influenced by the limited access to complement inhibitor therapy. And the largest data comes from the AIMS group. And since Aditi is in the audience, I'd like Aditi to comment briefly on the Indian experience of atypical HUS.
Thank you. Am I audible? Yeah. Thank you, Dr. Malina, for that talk. That was excellent. And we really enjoyed it. It was comprehensive. And we always look to Newcastle to bring in new advances in the field of atypical HUS. Thank you for presenting your unit's experience. So in India, Professor Bagga has, with the help of collaboration from French colleagues, helped set up some services for complement diagnostics. Chiefly, we have been fortunate in a way to have had a sizable fraction of Indian children with atypical HUS being diagnosed with anti-factor H antibodies to complement factor H rather than the other abnormalities, and that being the predominant cause for an unknown reason, because the genetic predisposition is fairly similar across the world in terms of CFHR1/3 deletion. That being the cause, we have been fortunate to be able to collate our experience and be able to find that plasma exchanges and immunosuppression works fairly well in this group of patients. So that's been useful for us. We continue to run the test for nationwide samples free of cost, thanks to funding support from various governmental agencies, including the DST, the ICMR, DBT, ongoing funding through projects. But the important bracket of disease remains atypical HUS, which is not mediated by anti-factor H antibodies. And therein, we are beginning to use next-gen sequencing to diagnose these cases and try to manage them well. But obviously, this challenge is because of limited access to eculizumab. We have had the occasion to use eculizumab recently in a few patients, and we can understand why everybody is so awed by this agent and how miraculously the children turn around with therapy. And that being the case, we understand why vascular access and other complications associated with plasma exchanges make it an inferior option for children with atypical HUS, not mediated by antibodies to complement factor H. Having said that, the expense of therapy makes it out of reach for any individual in the country overall because of the cost. We have now initiatives such as the Rare Diseases Initiative, wherein centers of excellence might have access to a limited amount of fund per patient, say up to a ceiling of 50 lakhs for rare diseases. And through that, we are trying to push for access to therapies such as this. But we do need to continue participation in clinical trials such as for crovalimab, avocapan, and other complement and pathway targeting agents, so that access to these medications is improved for our country. So thank you. I think
it was a great insight. I really appreciate, and I really enjoyed all the results that came also from your center on the antibodies. And I'm also baffled by the slight difference in this presentation.
Yeah. Hi, Michael. I'm Rajiv.
Rajiv.
So thanks for the talk. I wanted to have your experience on MCP. Like, we have in our center 3 or 4 MCP positive, and 2 of them are behaving as the textbook says, that like most of them relapse and then goes all right and is well. But the other 2 are behaving very badly, are having very frequent relapse, severe hypertension, a bit of a CKD. And so in your experience, what is your about the MCP, and do you use eculizumab? Obviously, we don't have that, but do you have any other suggestions?
So for all patients in England, when they are diagnosed with atypical HUS, and we exclude possibility of secondary type or STEC, we treat them all with eculizumab, including factor H antibodies and CD46. We have with the reports from CD46, we have seen quite a broad range from those ones that they are having several indolent relapses and they are continuing to have quite a good kidney function, to those that you say that they are progressing into CKD after even the first one, and they are difficult to control without any other option. There is a very limited efficacy of plasma exchange, unfortunately, in the CD46, as it is a surface-bound molecule. So they are really quite a candidate of probably the intermittent one treatment, because what we see, if the trigger passes away and we cover that period with eculizumab and then we stop, most likely these patients are safe. However, I have had several now adult patients referred with CD46 that they were in their 40s, around this age, and mostly they said, oh, I was having some kidney problem or hematuria when I was young, 3, 4. Then I was having another one when I was a teenager. They thought that it might be post-streptococcal or something like that. And then it nibbled to their kidney. And in their 30s, 40s, they were having very progressive CKD, or a few of them also almost at the end stage. And they were also complicated by hypertension. It looks like that when there is this struggle of the kidney for blood and the microthrombi are happening, that they are also presenting with quite high blood pressure.
Thanks.
Any other questions? If there is any post-transplant experience of atypical HUS to Dr. Malina?
Quite fortunate thing, again, with the change of the treatment. My first experience with atypical HUS was with a patient that I have met when he was 16. He was after 2 unsuccessful kidney transplants, having a C3 mutation. That was before the eculizumab, and it was horrible. This guy was mostly bound to dialysis, so he was fortunate that he could have had it at night. So he was at home dialysis even before it was more of a thing, because of very dedicated parents, and he was mostly sentenced to this life. After that, there was a found that he was carrying a C3 mutation. This could have been then changed because he was allowed to have eculizumab before his next transplant, and his transplant was working very well. So we know that patients, when they are covered with eculizumab and going to kidney transplant, the chances of relapse are very minimal. I don't have the slides here, but I could have find it. Most of our patients, where we have now put a report out about transplant experience, so it is also available from our center. Most of the patients are doing really well. The historical cohorts were much more dire, as in even my personal experience. We tend to treat not reactively most of the patients that we know that they are having genetic change. So they are given eculizumab pre-transplant. They are having an extra dose post-transplant covering for reperfusion injury. It's mostly out of caution, and then they usually continue on the complement blocking therapy.
Thank you. In India, we are frequently seeing the pregnancy-associated TMA. Anyhow, TMA is very difficult, whether it is a primary, secondary, malignancy-associated, infectious-associated. It is a very difficult and challenging case for everyone, and we have to be very alert. And the prognosis depend upon the early diagnosis, and the treatment is the comprehensive attitude from the nephrologist, physicians, and pathologist, hematologist, and the treatment is quite costly. So it's a nice discussion, and we are running late, and we conclude this session. Thank you for everyone.
Thank you.
Thank you so much, chairpersons, for conducting the session. And special thanks to Dr. Michael Malina, because for him it would have been at 6 a.m. in the morning delivering this lecture while we are preparing for the lunch. So special thanks to him.
It was a pleasure, and enjoy the lunch break.
Thank you so much, sir. Thank you. Hello, very good morning. I am Dr. Abhishek. I am a consultant nephrologist at Paras HMRI and the host for today. With this, we have reached the final and the concluding session of this very delightful CME. But this, I suppose, is the most important session for this whole CME. We start this session by a plenary session dedicated to late Professor Dr. I.B. Sinha, sir. The session is Dr. I.B. Sinha oration, Kidney Diseases in Kids and Odyssey. Late Dr. Professor I.B. Sinha is probably the father of nephrology in Bihar. So it's an honor for us to dedicate a session to him. For this, I like to call the chairpersons for this session. Dr. D.S. Ray, sir is the senior consultant and the chief of the renal transplant at the Department of Nephrology, R.N. Tagore Institute, Kolkata. Next, I'd like to call Dr. Professor Om Kumar, sir. Sir is the professor and head of the Department of Nephrology at IGIMS, Patna. I'll also like to call Dr. N.C. Prasad, sir. Sir is a senior consultant nephrologist in Patna and the ex-Director General of Health Services, Government of Bihar. Professor Dr. V.K. Singh, sir. Sir is a senior consultant nephrologist and ex-head of the Department of Nephrology at Patna Medical College, Patna. Request the chairpersons to kindly introduce the speaker and carry forward the session. Thank you.
Thank you, Dr. Abhishek. As Dr. Abhishek has mentioned that this is the most important session for this CME. Late Professor I.V. Sinha sir, popularly known as Indu Babu in the community of nephrology all over the country. He was born on 1st of January 1938 in Supor, Jamua village of Munger district in Bihar. He graduated from Patna University in 1960 and then joined the Bihar Health Services in 1961. Then he did his MD in General Medicine and Dermatology from Patna University. He was selected by the government of Bihar for his higher training in nephrology at AIMS New Delhi, CMC Vellore, Jaslok Hospital Mumbai, and then Royal Liverpool Hospital, UK. Then he joined as assistant professor in Patna Medical College, and he retired from that medical college as professor in December 1995. To his credit, he has started the first dialysis center in Bihar and Jharkhand. He was awarded Padma Shri by the President of India in the year 2008. He was conferred Master Teacher Award by Association of Physicians of India, Dronachar Award by the Association of Vascular Access and Interventional Renal Physicians, Lifetime Achievement Award by Tanker Foundation in 2017. He was member of Advisory Committee of Nephrology of the National Board of Examination and member of Board of Appointment for faculty members in various central universities, including Banaras Hindu University. He was editor of Patna Journal of Medicine for several years. He was president of Indian Society of Nephrology in 2000 to 2001, and he was organizing secretary of Indian Society of Nephrology annual conference held in Patna in 1999. So this is the only annual conference of ISN which has held in Patna, and we are still trying to hold the second conference in Patna. He was president of Association of Physicians of India and Bihar branch, and president of Indian Medical Association Bihar branch. For us, it is a very emotional moment, and this is the first CME we are doing without his physical presence. I am thankful to Madam Kumudini Sinha that she is present for this oration function. Please give her a great round of applause. And now I request my co-chairperson, Professor Dr. D.S. Ray, to introduce the speaker for today's oration.
Good morning. I thank both Professor Hemant Kumar and Dr. Om Kumar for inviting me to chair a session in the name of Professor I.V. Sinha, who has been a father figure to all of us in Eastern Zone. No conference has been complete without Mrs. and Professor Sinha being there, and it will never be complete also. We'll always feel his absence in the conference. It's
good that we are having a stalwart Professor Gulati, who is not only a pediatric nephrologist, he is also an adult nephrologist, is president of Indian Society of Nephrology, lot of research work and lot of work on transplantations. So we are eager to hear him. Professor Gulati, please.
Madam Sinha, Professor R.N. Srivastava, Professor Vivek Jha, distinguished delegates on the dais as well as audience and dear friends. It is an overwhelming occasion for me to be honored for this oration. Professor Sinha has left a legacy, and as you can see, some of the biggest names in international and national nephrology have been his students. And I've had the privilege of interacting with him when he was the president as well as the secretary of the Indian Society of Nephrology. So I'll be sharing with you my experience in managing kidney disease in kids over the last 3 decades or so. But first of all, to start with a quote from none other than late Nelson Mandela, that there can be no keener revelation of a society's soul than the way in which it treats its children. Because after all, children are the future of the country. So during my tenure, I've looked at the problems of UTI in children, hypertension, nephrotic syndrome, acute kidney injury, crescentic glomerulonephritis, chronic kidney disease, CAPD, kidney transplant, some management during the COVID, and also some role of telemedicine, and be touching briefly on some of those. So we started by looking at UTI in children and highlighted how they are important, not only in children, but also in nephrotic syndrome, triggering relapses, in kidney transplant patients, and also the role of DMSA scans in following up these children for incomplete resolution and progression to chronic kidney disease. Hypertension was another area of work, and we looked at malignant hypertension in children and how aortoarteritis was an important complication. The spectrum of reversible posterior leukoencephalopathy in these children, and we highlighted certain atypical findings. Also, this was that resolution is not always complete. Nephrotic syndrome has been a particular area of interest for me, inspired by Professor R.N. Srivastava, who was my examiner during my MD at PGI Chandigarh. And these were several papers that we looked at, looking at the steroid response pattern, looking at intravenous cyclophosphamide, treatment of children, the need for awareness, especially in the general community, spectrum of infections, and we highlighted that UTI and tuberculosis are 2 important infections besides peritonitis in these children. We looked at FSGS, duration of optimal therapy, factors predicting remission in steroid-resistant nephrotic syndrome. And this is some of our work which has been recognized at the international level. Indications for kidney biopsy, we identified certain novel trends in histopathology, highlighting the increased evidence of prevalence of FSGS, how, again, steroid-resistant nephrotic syndrome, the histopathology is changing. 2 treatments, intravenous cyclophosphamide and tacrolimus, which we were fortunate enough to publish from SCPGI and form a part still of the 2021 IPNA guidelines, bone diseases and nephrotic syndrome, and work on genetics. But first of all, this was a paper which was published in Pediatric Nephrology 2002, and we re-looked at the guidelines in light of our experience, and we said that it's time to revise these guidelines, and kidney biopsy should be restricted to children whose nephrotic syndrome is under 1 year of age, if they are not responding to 4 weeks of prednisone, unusual clinical or biochemical features, and if you are using cyclosporin. And this was an editorial in the same issue of Pediatric Nephrology, where the IPNA said that yes, it's time to revise the guidelines. This was followed by a consensus conference, and it indeed resulted in a change in the guidelines, and biopsies were no longer done in frequent relapsers, steroid-dependent children. This was another seminal paper on the changing trends of histopathology in childhood nephrotic syndrome, published in the American Journal of Kidney Diseases. So what we found was that over 2 different time periods, as you can see, the prevalence of focal segmental glomerulosclerosis had increased. This was also quoted in a paper by Eddy and Simmons in Lancet 2003. Studies from different parts of the world, Saudi Arabia, North America, USA, including our study, from India showing that over those 2 different periods, the prevalence of FSGS as a cause of nephrotic syndrome had doubled, again telling us that it was no longer as easy to manage as it was earlier on. Again, the cause for this needs to be identified. This is a paper published on looking at the spectrum of histopathology in steroid-resistant nephrotic syndrome, published in Indian Pediatrics 2006. We compared our data of 136 steroid-resistant children with 103 for the ISKDC study. So similar findings here that the prevalence of FSGS had nearly increased 3 times. The mesenteric glomerulonephritis was coming down because of the infections. Again, minimal change remained an important component, but again, FSGS was an important component. This was our landmark paper, a randomized controlled trial of intravenous cyclophosphamide in steroid-resistant minimal change disease. So mind you, this was done in 1994, and at that time, there were very little that we could do other than use oral endoxifen. So in this paper, we compared intravenous cyclophosphamide with oral cyclophosphamide. And what we found was that not only there was a significant improvement in the remission rate, but it's also the remission came at about a 40% lower dose. And this again has been highlighted in the 2021 IPNA guidelines, and as recently as 2021 paper by Lavjai Bhutani also, this paper, protocol has withstood the test of time and remains one of the important therapeutic protocols in management of steroid-resistant minimal change disease. There is a similar protocol that we use in steroid-resistant FSGS, a higher dose of 750 milligram per square meter, a definitely lower remission rate than what we observed in minimal change disease. Not surprising, because this was a mixed bag, and I'm sure a subgroup of these FSGS were genetic FSGS. We also found that it was far more economical than the innovator brand of cyclosporin, which was all we had. So, at least in our patient population at SCPGI, majority of them could not afford cyclosporin, and response was better in secondary steroid-resistant nephrotic syndrome. We also used a similar protocol of pulse cyclophosphamide therapy in 2 different subgroups of steroid-dependent and frequent relapsing subgroup nephrotic syndrome. And what we found was that responses were very good. There was a 42% complete remission rate in the steroid-dependent group. There was about 31% improved and became infrequent relapses. Another 17% were frequent relapses. Only 10% continued to be steroid dependent. In frequent relapses, this was even better. 68% of these attained complete remission, 18% frequent relapses, and 14% continued to be frequent relapses. And this work on intravenous cyclophosphamide was recognized by the Indian Council of Medical Research. This is our work on tacrolimus, a new therapy for steroid-resistant nephrotic syndrome, which was among the first few studies from all over the world. And till today, this remains one of the most optimal therapies for steroid-resistant nephrotic syndrome. 22 children were looked at. Mean age of onset was 7.3 years. Mean time to achieve remission was about 63 days. Mean TAC dose was 0.18 milligram per kg. And the mean duration of follow-up was 290 days, and 84% complete remission, 11% partial remission, and a 5% were non-responders. And this forms the gold standard of therapy today also as far as management of steroid-resistant nephrotic syndrome is concerned. This is some of our work looking at metabolic bone disease in children. We looked at 100 children with nephrotic syndrome, and we found that although we are using steroids left, right, and center, 57% of them had osteopenia, whereas 29% had very severe osteopenia, which in adults we call osteoporosis. Whereas when we looked at the symptoms, only 8 of these children were symptomatic. So this was another problem that we were perhaps creating inadvertently while treating in an attempt to treat these children. This is a subsequent follow-up study in nephrology dialysis transplantation, prospective work in 100 children with idiopathic nephrotic syndrome and normal renal functions. And what we found was that the factors that were predictive of an improved BMD delta Z score, which is how we look at bone disease in nephrotic syndrome, are younger age at bone density, calcium and vitamin D supplementation, a greater calcium intake, and lower steroid disease dose per year, again highlighting the need for early intervention with non-steroid protocols, and also using calcium and vitamin D supplements, which is again now in the IPNA guidelines as far as management of nephrotic syndrome is concerned. This is my paper in NEJM. This was a paper by Mary Leonard's group from US, which actually reported quite contrary, and in their group, they didn't find any relation of steroids with low bone densities. But what we pointed out was, first and foremost, there was no correlation of the doses of steroids with the bone mineral content. They had done bone mineral content and not bone densities. The Z scores of their spine were definitely lower in patient subgroup as compared to their control group. Again, no information on the dietary calcium or vitamin D intake, and a lot of food supplementation is done in US, which might have resulted in protective effect of the steroids. And genetic factors was certainly an issue as to why we may be seeing more osteopenia, osteoporosis. This is subsequent work from SCPGI looking at genetic factors, and we did identify certain genotypes which were predictive of low BMD scores, namely the TAC-A1 and APA-I1 genotype of the vitamin D receptor gene, which could be predictive of the low bone mass. Again, nephrotic syndrome, we all know, is a genetic disease. For steroid-sensitive nephrotic syndrome, we still do not have any etiology, and this is some of the work with HLA markers, and we were able to identify this unique marker, which was perhaps predictive of steroid resistance, and the hypothalamic susceptibility gene of steroid-resistant nephrotic syndrome could be perhaps located at the DR beta 1 150X and DQ beta 1 060X haplotype. So these are two books. This is the childhood renal disorder group, which I was an editor, and I've also contributed a chapter on steroid-resistant nephrotic syndrome and the IAP textbook of pediatrics. Nevertheless, steroid nephrotic syndrome, is a difficult disease to, and this is to quote Louis Barnes, that few diseases tax the resources of the practitioner so extensively as the nephrotic syndrome. He must be a combination of an infectious disease expert, nutritionist, physiologist, psychiatrist, pediatrician, and nephrologist for the patient, and above all, guide, counselor, and friend to parents. So it remains a difficult disease to treat, whatever we might think. This is some of our work in acute kidney injury. We looked at the pattern in a referral hospital, namely SCPGI, and we were able to identify that HUS was coming up in a big way. This is looking at cardiac tamponade, peritoneal dialysis, and we also used plasma infusion in atypical HUS, and this was obviously in the pre-eculizumab and pre-rituximab era, where we were left with very little, but at that point of time, this did benefit these patients. This is our experience with the crescentic glomerulonephritis, which is like a medical emergency as far as children are concerned. And in our spectrum, the immune complex glomerulonephritis was the commonest cause of crescentic glomerulonephritis, followed by anti-GBM disease and post-immune glomerulonephritis was an important cause. The outcome was not good because there was a delayed diagnosis and referral with a mean duration of symptoms of nearly 2.5 months prior to referral. By that time, fibrosis always sets in. High frequency of chronicity changes was seen on kidney biopsy. We found fibrocellular crescents and glomerular cirrhosis. And what we concluded was that a greater awareness of this entity needs to be created amongst the pediatricians so that we have an early referral. And I believe things have changed. As I spoke to Dr. Badoria, my junior colleague at SCPGI, that they are seeing a change as far as the pattern is concerned. They're getting these patients earlier. This is some of our work on chronic kidney disease in children. This was our first paper on the etiology and outcome of chronic kidney disease in Indian children. And we see that Kakut was the commonest cause, followed by glomerulonephritis and hereditary diseases in a small component. But what we also found was that, a lot of this chronic kidney disease is reversible. About 1/4 of these children had reversible factors like volume depletion, NSAIDs, infections, and hypertension. And if you pay attention to these issues, there is dramatic improvement in kidney function. And these families remain indebted to you for improvement in kidney function in what is otherwise a progressive disease. What we also concluded was that the prognosis by and large was poor in these children because of late referral, limited availability, and high cost of renal replacement therapy. This is our outcome data. As you can see, the moment CKD was diagnosed, 39% straight away opted out. Another 17%, another 21% opted for conservative therapy, 8% died, and this was really opted out. Very small number of subgroup persistent in dialysis, and just 17% opted for renal transplant, which is the definitive therapy as far as chronic kidney disease is concerned in children. And these are the different options. Some of the children that we have managed, you could use CAPD, hemodialysis, kidney transplant. This is our first paper, one of the largest from our country, on continuous peritoneal dialysis in children, a single center experience. We looked at 30 children, mean age of 13 years, mean follow-up of 15 months, a mean break-in period of 12 plus minus 3 days were given. The peritonitis rate was acceptable. And mind you, this was done using continuous ambulatory peritoneal dialysis because of cost constraints, and not APD using the cyclers, which is by and large, is not affordable in our country. And what we found was that it was a useful modality with a mean cumulative survival on CAPD of 45 months. This is a subsequent follow-up study published by Narayan Prasad of some of our patients. There are 66 patients. The number pool had increased. Mean age was 12.3 years. The total duration of CAPD was nearly 108 years. The mean patient survival on CAPD was 41 months, and the mean death-censored technique survival was a very impressive 54.5 months. And 42% of these children were attending school time, despite using this intensive CAPD protocol, 9% part-time also. This is one of my papers published in Kidney International, looking at the issue of technique failure. Our experience from Sick Kids Toronto, where I had the opportunity to do fellowship. And the two factors predicting technique failure was low serum albumin at 1 month and recurrent peritonitis. By highlighting the need of aggressive nutritional therapy in these patients, especially who are on long-term continuous peritoneal dialysis. Some of our work in kidney transplant, way back in 1995, we had an editorial highlighting that kidney transplant is the optimal mode for renal replacement therapy, and we should be moving towards preemptive kidney transplant. Our subsequent experience published in Indian Pediatrics 2001. We have also looked at factors influencing growth and final height after transplantation and the outcome of pediatric transplants in a developing country. This is one such child. We did a preemptive transplantation. And what we highlighted was that it has advantages in terms of economic, that you save on the cost of dialysis. It minimizes malnutrition, uremic complications, infections, and these patients have a far better outcome as compared to those who were subjected to dialysis and then went ahead with the kidney transplant. This is our initial experience of pediatric transplants from SCPGI, 39 patients, one of the largest at that point of time. 1 year survival 89%, 3 years 70%, 5 year going down to 50%, because of poor compliance, because at that time innovator cyclosporin was the only brand that was being used. Subsequent studies, follow-up study, this is our experience published in Journal Nephrology and Renal Transplantation with 50 patients using the TAC MMF prednisone. As you can see, 1 year survival here, 98%. Graft survival, 5 years, 85%. Again, a lot of industry contribution because the generics had become available, and highlights how the Indian generic industry has contributed significantly to improved outcomes as far as kidney transplantation are concerned. What are the factors looking at influencing growth and final height after renal transplantation? Some of the experience during my fellowship at Royal Children's Hospital, Melbourne, Australia. Etiology, age at transplant, pre-transplant growth, renal function post-transplant, steroids, renal osteodystrophy, and post-transplant sexual maturation. And what we also found was that alternate day prednisone is a very cheap and effective way to improve height after transplantation, especially in our country where growth hormone remains beyond the reach of the vast majority of the patient population. This is some of our work during COVID. And as you know, COVID struck us like a bolt from the blue. And I think children were the most vulnerable of the lot, because even after vaccine was introduced, children were denied vaccination. And the only way to continue to take care of these children was through telemedicine. This was published in Pediatric Nephrology. And what we concluded was that a low-cost telenephrology model, using simple WhatsApp, along with an email and an electronic medical record, offered an effective method for providing continued pediatric nephrology access during the period of pandemic lockdown, when access to pediatric nephrology care was limited. This is a follow-up study where we continued using this low-cost model. And pediatric nephrologists are not easily available in each and every city. A lot of these families have to travel large distances. And what we found was that telemedicine is a useful modality in following up these children. And it helps also in triaging these patients who need to come to a higher center for follow-up. Therefore, it is cost-effective and time-saving for the family, and helps in improved compliance with therapy, which often, results in loss of earning for the family members when they come for follow-up. And last but not the least, this is the role of the nephrologist in bridging the knowledge gap, which was last World Kidney Day's motto. But this theme is very relevant today, because a lot of our patients, are misguided by social media, who they consider as the final frontier. We have a lot of patients going to Facebook, Instagram, Twitter, and YouTube for trying to find out the best therapies. And it's not surprising that they are misled, and they often end up spending lakhs of rupees, which could have perhaps been very optimally utilized in improving the results of therapy. So during this pandemic, I launched my own YouTube channel, and this is currently, I think I have more than 30,000 subscribers, more than 20 lakh views. And we also now, after I've taken over as the president of the ISN, the Indian Society of Nephrology also has launched its own YouTube channel to give these patients an authoritative view, an alternative view, and also bring them up to date with, what the recent advances in therapeutics in the field of kidney diseases. So I would like to acknowledge several people. First and foremost, Professor P.D. Gulati, who inspired me into nephrology, Professor B.N.S. Walia, who is the head of pediatrics at PGI Chandigarh, and always, egged us to do much more than pediatrics. Professor Vijay Kher, Professor R.K. Sharma, Professor Amit Gupta, who were my teachers at SGPGI, and Professor Narayan Prasad, who's been a key collaborator for much of my work, and he's carried on some of the work that we initiated. Professor Harley Powell at Royal Children's Melbourne, Chris Reed at Guy's Hospital, UK, Alan Watson at Nottingham, Bill Balfe at Sick Kids, Dennis Carey at Sick Kids, and Brian Steele at McMaster Children, where I, and not to forget my wife and two daughters who have been here, and also the patients, who reposed the faith in me and persisted with our therapy, some of which may not have been very good. So, and on this note from Robert Frost, that a lot has been done, but a lot more needs to be done. And we have promises to keep and miles to go before we sleep. Thank you.
Thank you, Professor Dr. Gulati, sir. Professor Dr. I.V. Sinha was my mentor, and I worked under him as house physician. And I was with him throughout his life at PMCH. I also give my thanks to the organizing committee that they have started ORASM program. I also thanks to ma'am that she has come here to give us blessings. We are always in need, ma'am, and we are expecting you will give us blessings. Thank you.
May we request Madam Sinha to hand over the medallion to today's speaker, Professor Gulati.
Kumudni Sinha ma'am, please come on this. And may I also request Dr. Professor Hemant Kumar sir to present the medal to the speaker, Dr. Sanjeev Gulati, sir, and madam. The medal in name of Dr. Professor I.B. Sinha being presented to Sanjeev Gulati, sir.
Give a homage to our reverend teacher, Professor I.B. Sinha. And this is a really a moment where we must pay regard to our madam, Dr. Professor Kumuddin Sinha, who has taken all the emotions here to share the moments which we spent a long back for a long journey with Professor I.B. Sinha. Thank you very much, madam, for coming to this forum and giving your blessings to all of us in this assembly. Thank you very much. And I will request madam to speak a few words.
Good afternoon to all of you. Sorry, good morning to all of you. Please be seated. As Dr. Hemant has asked me to say few words, I'm thankful to him. Rather, that is I am here because of Dr. Sinha only. And so all of them who are here, they have given me a lot of love for him. And that is the nephrology here is the extended family of now. I don't have the idea of any protocol, but I start with organizing chairman, Dr. Hemant, organizing secretary, Dr. Om, dignitaries on the dais, off the dais, distinguished guests, faculties, ladies and gentlemen. When Hemant came to me on Wednesday to tell me that you have to come to give this medal, I was taken aback. Really, I am saying that I was taken aback. There are a lot of important personalities for giving this medal. But for me, it come a dream come true. It is honor for me. Rather, I'm feeling privileged and grateful for giving me this honor to give, as I have given it already, to, and that is the I.B. Sinha Oration 2023 medal for his excellent and legendary talk on kidney disease and children. Now, it was a memorable moment for me, and it will remain in my mind for my lifetime till I am alive, that I have given this medal to a legend in the memory of the another legend and the father figure of nephrology, Dr. Sinha. I can say him, though I shouldn't say that, he was a complete personality and a perfect package of everything. Teacher, father, husband, friend, and everything. now I see the seed that was planted, I think about 4 decades before, with few members, it has turned into a big tree now. Because there are so many nephrologists here in Bihar itself, and that seed was planted. I don't exactly remember the day, but that seed was planted almost 4 decades ago with 4 or 5 nephrologists of Bihar. Now there are more than, I think about 35 or more than 35. So he must be looking from there, from heaven, and he must be thinking that this big tree should give shadow in form of care and concern, and treatment in form of fruits to the ailing society and ailing humanity. I'm thankful again to Dr. Om, Dr. Hemant, ISN members, ISN East Zone, all the committee members of this CME 2023, and all the persons and the nephrologists for giving me this honor and making my day memorable for my life long. Thank you very much. Stay blessed. Thank you so much.
Thank you, madam. Thank you for your blessings to this entire session. Through you, we have seen Dr. Professor I.B. Sinha today. Next, we will move on to the next session. This is a panel discussion session. And for this session, I like to call upon the chairperson, Dr. D.S. Ray, sir. Sir is a senior consultant and the chief of renal transplant, Department of Nephrology at R.N. Tagore Institute, Kolkata. I'd request D.S. Ray, sir, who is already busy, but after he finishes off the photo session, then please come to the chair and kindly introduce the panelists and the moderator for the session. There's a slight change, as sir has already announced. So the chairperson, I'd like to call Dr. Professor Ehsan Ahmed. Sir is a professor in Department of Urology, IGIMS Patna. Dr. Ehsan Ahmed, sir, kindly come to the chair and introduce the moderator as well as the panelists for the session.
Thank you. Today, the session on the pediatric transplant challenges. The moderator is Senior Consultant Pediatric Nephrologist, Dr. Rajiv Sinha, Institute of Child Health, Kolkata. I welcome on the stage dash. Dr. Rajiv Ranjan Sinha, sir. Please come.
Yeah.
The panelists for this discussion, they are Dr. Arpita Rai Chaudhary, Dr. Pardeep Chakravarti, Dr. Subal Pradhan, and Dr. Anshuman Saha. They are also requested to come on the stage.
So shall we start?
Yeah, we shall start. Please, sir.
Thank you, sir. Sorry for my voice. I'm recovering from a cough and cold. Maybe I didn't know. I don't know, but not COVID. So we will be talking about the pediatric kidney transplantation. And at the onset, I'd like to thank the organizing team and particularly Professor Hemant Kumar for bringing this amalgam of pediatric and adult nephrologists and pediatricians. Obviously, I will not be covering all the challenges and solutions, and we will be focusing on few of them. And we all know what are the challenges, starting from knowledge barrier to lack of access of appropriate healthcare, social barriers, economic barriers, and medical surgical barriers, and policy barriers. Again, we won't be covering all of them, but hopefully we will be touching on most of them. So we start with our first case scenario of this 5-year-old girl. So she presented initially when she was 9 months old. So this is her initial picture with a CKD from bilateral dysplastic kidney. Went on to CAPD at 3 years. And when she came to us, she was on CAPD for the last 3-4 years. So my question is that should we be thinking of a kidney transplantation in this child? This child seems to be doing well on CAPD, attending school. So, and this question is for Subal, Dr. Subal Pradhan.
Good morning to all. At the outset, I would like to thank the organizers for the invitations and wonderful hospitality. So as you all know that transplantation is the treatment modality or preferred treatment for all cases of end-stage renal disease. It has significant survival advantages. Besides, also it confers improvement in quality of health as well as growth and development. In the previous session, so Dr. Gulati has highlighted that all these transplantations helps in to achieve the catch-up growth later on, before less than 6 years of age.
So as this slide shows, what Dr. Subal said, that the transplantation is the only way in which you can achieve 50% of the kidney function. I don't need to preach to the nephrologist, but there are pediatricians around who would like to appreciate this. And if we don't catch the worm early, then we will miss the worm, because if you don't do the transplantation early, then you don't have the catch-up growth. And often in India, and this is something we'd like to emphasize, that we say that बड़ा होने से किया जाएगा, 10 साल, 12 साल, 14 साल उसके बाद transplant करेंगे. But then adolescents have the worst prognosis in pediatric age group. We all know that for kidney transplantation, and we also mentioned on the catch-up growth. So we all agree, I think all the panelists agrees that we should go for the kidney transplantation in this child. So this question is for Anshuman, like what is the most important requirement for kidney transplantation?
So basically, when we are planning for kidney transplantation in children,
So three things we have to evaluate, like evaluation for the.
But what is the number one thing you require for the kidney transplant?
There should be a donor available.
So we should have a kidney, right?
Yes.
Everyone agrees. And this was a picture drawn by a child, not in India, from Gauss, who was on dialysis. And what she said that if someone is willing to donate a kidney to you and it matches, nowadays we can even do without matches, you can have a kidney transplant. So you require a kidney. And next we will come to Dr. Pradeep Chakravarti, that who can be a donor?
The best donor or preferable donor will be somebody who is we call a living related or a living kidney donor, either related or unrelated, HLA compatible and ABO compatible. Next will be a deceased kidney donor. The results are a little less because of more attrition to those kidneys when they're procured. And I would not recommend pediatric donors for pediatric transplantees.
So very succinctly said, this is a list of pre-transplant workup, which I'll not go through it. And as Dr. Chakravarti said, that living better than deceased, but no kidney is the worst thing. Donor age 18 to 49 is supposed to be very good for pediatric. And if you are having a matched kidney, it is better. So now we have decided that the mother has said that she is ready to donate, and mother was worked up, was normal. So Angshuman, what else information do you want?
So we need to assess the risk of rejection, the risk of infection, and more importantly, particularly in children, evaluation of the lower unit tract, whether it is ready for transplantation or not. So in the evaluation of immunological risk, what we do is a basic HLA of both the donor and the recipient, and look for presence of any donor-specific antibodies by doing a lymphocyte cross-match, and preferably flow cross-match or at least one single bead antigen assay. For evaluation of infection risk, most important thing is the immunization. The patient should be immunized completely. The anti-HBs status should be more than 10. Varicella immunization also is very important. And we evaluate for the CMV positivity also. And regarding the evaluation of lower unit tract, because most of the ESKD are acute. So even if there is no hydronephrosis, the patient should be completely evaluated for lower unit tract, like right from the history of recurrent infections, the voiding diary, a MCUZ, and if required, UDS.
So what is important, I think a bit difference from the adult will be the evaluation of the bladder. So because many of these children who going to ESRD are from bladder dysfunctions. They might be having reflux, dysplastic, or valve neurogenic bladder. So that is the most important message. In this child, everything was okay. We went ahead. We were thinking of going for transplant, but this child is just about 12 kilos. So my question is to all the medical nephrologists, does size matter?
No, we are very comfortable in the adult segment with urologists doing well with more than 15 kg. I think in pediatric transplant surgeons who are used to do with pediatrics, they are now doing even below 10 kg. So 10 to 15.
But does size matter?
Size of the child. No, weight of the child does matter, but not the size. And the kidney size is, adult kidney size is quite acceptable, as already Dr. Chakravarti mentioned.
So in pediatric KT, definitely size does matter, because it does, like we can do it, but it does comes with the challenges. And Dr. Chakravarti, if you can elaborate on the challenges and some tips.
This is a very important question, and quite very much asked from the surgical standpoint. Size matters, depends on the experience and the expertise of the care provider, I personally categorize children for receiving a kidney into 3 weight categories. The smallest, 10 to 15, or let's say 10. Then the next category is 10 to 30 kilograms, and the third will be above 30. So and then it depends. If they are in the first group, you need to place the kidney at a higher position, lower aorta, and you can go for the common iliacs if they are in the other 2 groups. Mind you, one thing is very important from the surgical technique in doing this is the area of anastomosis, or let's say the circumference of anastomosis is very important, because if in a very young recipient, if this anastomosis is has a small surface area, when the child grows, it causes renal artery stenosis, and which leads to uncontrolled hypertension and renal dysfunction. So that is important. And also a second, which is a part of physics that we learned in school, is if the renal artery or the allograft artery should be, the diameter of that artery should not be more than the diameter of the feeding artery. So that is an important point. And if you keep these 2 in mind, I think it really helps.
So bottom line is that size does matter, but then it can be overcome if you have got the anesthetic expertise, the surgical expertise, and the post-surgical management in the medical expertise. We did this survey way back in 2017, and there were very few centers across India, and only 1 or 2 centers in Eastern India who were doing pediatric KT in large numbers, and hardly any within less than 15 to 20 kilos. And this slide mainly to show that yes, within less than 10 kilos also you can do transplant if you have got expertise, but then this should be restricted to very selective number of children. Ideally is that you should make them grow well by good nutrition and good dialysis, and then once they are 10 and above, then transplant. So this child was transplanted successfully, and this is very recently. So this is a child who was diagnosed at 9 months with CKD, went on to have a CAPD from 3 years, now is about 13 years and dancing. So things can be achieved. We move on to a 8-year-old boy who was operated meningomyelocele and then presented to us with ESRD and was ready for the transplant. But are we ready for Pitadi?
We need a safe bladder. This child, by presence of meningomyelocele, gives a clinical pointer that he might be having a neurologic bladder. So compatibility of CIC, doing CIC with the family and the child during counseling, and a workup with video urodynamic study, so that we can look at the capacity and the pressure of the bladder and advise for an augmented bladder creation.
So firstly, I would say it was criminal that this child went into end-stage renal failure after being operated at within 1 month. Why? No, because according to the family, nobody had counseled them for CIC. They were under follow-up, but nobody mentioned about CIC. So it is a criminal, and it shows we are sending men to the moon and blasting nuclear bombs, but we still have a lot to do. Sorry, it's my personal opinion. So this child actually had a neurogenic bladder, as you can see, and as Arpita said, that needs a safe bladder. So in this particular child, because this bladder was so small, we went for an augmentation and mitrophenol. This is the mitrophenol, how it is done. Like you can put in the catheter through your tummy. And the child was transplanted successfully. So Luto, we heard yesterday also, lower urinary tract obstruction does give us a lot of challenges, but again, these challenges can be overcome. This particular child also had a PUV, but then had a stable bladder. So we went on with the transplantation, and this child is now almost 10 years gone and is doing quite well with a creatinine of 0.7. This one was the child that I just showed. This one is a very peculiar case. This child came with had a PUV, went on to have ESRD, and when this child came to us, this was the anatomy. So you see, what they had done in Vellore was to save the kidney, was that they had anastomosed both the ureter and it was coming out in a conduit, like a ureterostomy. So we said that your bladder has to be made safe. You will need one surgery for making the bladder safe, and then we will implant your kidney into that new bladder. But this child said, I don't want any other surgery. I have undergone, by that time had undergone 4 surgeries. The only surgery I agree is a transplant, otherwise I'll not do. So after a lot of counseling, this was done. This is what the child agreed, that okay, you will do just the transplant surgery, and the new transplant ureter was anastomosed into that old stoma that was coming out. Now this child is 21 years old, has moved over to UK for further studies, and he's still happy with this. I have told him that, how are you finding a girlfriend? But he apparently has found one girlfriend also. So I don't know. It all shows that we don't appreciate the patient perspective, because I had a real fight with the child and the family at the start, but he seems to be doing very well. Moving on to our third one is the child with ESRD with FSGS. So again, Arpita, how would you counsel the family?
Yes, you need to classify them whether they are primary FSGS or secondary FSGS or a genetic FSGS. This goes the first thing. If you think that it is a idiopathic primary FSGS, then you have to counsel the family that at least 1/3 may come back, and there is an increased risk of losing the graft if it does come back. Definitely those who come back, in whom the recurrence is there, it's not that everybody proceeds to graft failure. Around 47 to 50% did have an improvement and can continue after plasmapheresis and nowadays with retux. But definitely a lot of counseling is required, and we should ask them to go for a genetic testing, so that if the genetic testing comes positive, as the data shows, that genetic FSGS recurs least rather. So we have a comfortable zone of counseling that yes, you are least likely to get the disease back.
So from my own practice, what we have found is that when I counsel the parents that there is a chance of recurrence, then the usual thing is that kidney bhi jayega, paisa bhi jayega. We will lose both the kidney as well as the money. And in India, it does matter. Deceased donor transplant is often not available, and that also involves money. So we did this study from our own center, and INSENT was also involved in this as a guide. And what we found was that if we are counseling them with a genetic report, then the chances of saying yes to transplantation increases significantly if you are counseling without. So with a genetic report, you are saying that go ahead with the kidney transplantation, there is less chance of recurrence. So we went ahead with the genetic counseling, genetic test, and this child, this is the index child, came up with a compound heterozygous and for the COL4 mutation. Unfortunately, both parents were carrier, and as you know that you shouldn't go ahead with this in COL4, and they underwent a transplantation by unrelated. We move on to our fourth case scenario of bilateral dysplastic kidney. The child is CKD stage 4. GFR calculation was 16, was quite tall and healthy, but is complaining of difficulties in keeping up with the peers. So, Dr. Subal, do you really need this child? Needs a kidney replacement therapy?
So, eGFR is not the sole criteria for taking decisions for considering transplantation, particularly in children. Because there's so many other factors, particularly in children, like growth and development. If the child having a persistent growth failure or developmental delay or persistent metabolic acidosis or on multiple drugs for hypertension, such children should be considered for
So,
transplantation.
so again, quite different from the adult here is that these three aspects, we really consider it more seriously. And we all have agreed already that transplantation is the best way forward. But then this child is not on dialysis. So should we start dialysis and then transplant, or should we go for a preemptive transplant? So Arpitadi, your comment on preemptive transplant.
Yes, of course. Preemptive transplant, particularly in the, we consider at the CKD stage 4, it is very important to pick up preemptive transplant in children because the growth issue is strongly there. And we know that the transplant answers best in terms of growth, in terms of other quality of life issues. So what I would like to say here, that there is a 2014 amendment of the HOTA Act, and grandparents may be included as the first living donor to the child for preemptive. As still not, there is a allowance for enlisting them for deceased donor if they are without dialysis. And one more thing, we may work up with NOTO to include the children in preemptive state only with for dialysis. And one more thing, that deceased donor enlisting should be done more and more for these children because they have many extra points. So they can come up if the organ is available from, they can surpass the adult supersede patients enlisted above, and then they can come up and get before the average waiting period. As Eastern Zone is already in Kolkata.
We will be coming to that.
Odisha.
Yeah. So preemptive kidney transplantation does have advantages. And this was the last one is a study from us only from Great Ormond Street Hospital, where we showed that if you have transplanted them preemptively, then you have a better CKD parameters. But the father, being the single bread earner, is afraid to donate. So Dr. Pradeep Chakravarti, how do you counsel him? Yeah, because he said that I am the bread earner. So how will I donate?
Father or mother, they're optimum donors for their children, being one haplotype match. Counseling them should be very straightforward, should be very honest, and you have to tell them that they're going to undergo a major procedure. We do our transplants, donor nephrectomies laparoscopically, and they get admitted the day before, day of operation. They get the laparoscopic donor nephrectomy, and nearly 80% of our donors are discharged the next day or the day thereafter. So this really matters, that how many days I'm going to stay in the hospital, and then what can I do after, am I going to be as I am now? So we need to tell them to get in touch with some of the donors that we have.
Yeah, that's often a good idea.
And the most important thing is that to reassure them that we statistically it is shown that when they have people who have donated 10,000 donors, round about 30 end up with chronic kidney disease after a period of 15 years. And in comparison to the general population, we're around about more than 326 approximately when they're followed up. In general population end up with chronic kidney disease. So their chances is 1/10 compared to the,
maybe because of the more closer follow-up.
So yeah, so these reassures them, and I think these are the basic things that they need to know and go ahead with.
So this is the father.
Hello, I am Ujjal Roy, father of Upam Roy. As told by Upam, I am the living kidney donor for my son Upam. Donation of kidney is very easy, and
So
it
this
takes
father is an
days
engineer,
to
and
stay
he was back to work within a month
in hospital.
And this is the child.
Hello everybody, myself Upam Roy. So a few months ago, or better to tell 7 months ago, I underwent live kidney transplantation. Why? I was suffering from CKD or chronic kidney disease, stage 5. My creatinine level suited to 5.9, which was very critical. So as told by my doctor, undergoing transplantation before the starting of dialysis gives a very better output. So living donation was must for me, so my father decided to donate. Before transplantation, I cannot concentrate in study, or
So
I got exhausted.
he goes on to say that before he was this, now he is much better. And I usually show this slide to the family, and sometimes it makes difference. So this child was transplanted. We are going on to our next case scenario. A child with a WT1 mutation had a nephrectomy at 1.5 years because of Wilms tumor, but then also had a nephrotic syndrome, and then went on dialysis and now is hypertensive. But the family is very eager for transplantation. So are we ready for the transplant?
As we discussed before, this is a genetic FSGS, so that's
So
a very
then
good
he will
prognosis.
not relapse.
He will not, so that's a good thing. So
So
we can
are we
proceed.
ready?
We can proceed, but the nephrectomy has been done for, I think, for hypertension.
One side has been done, the other kidney is still there.
But still refractory hypertension is there. So in that situation, we can consider native kidney nephrectomy. But native kidney nephrectomy is usually not done and not required in pediatric kidney transplant. There are some indications that have been listed here.
So this is like we hardly do a pre-transplant nephrectomy, but in this particular child with 4 antihypertensive and also with a WT1 mutation, we went ahead with the nephrectomy, and then the child went on to have a transplant done. Questionnaire 6, as a 6-year-old boy, end-stage renal failure secondary to ARPKD, was on dialysis. The current weight is 13.6 kilo. We have already known that weight is a challenge but can be overcome. But the blood group of child was O positive, mother is B positive, and father is O positive and is hypertensive on 2 drugs and is having significant proteinuria. So what are the options for his kidney transplant? We thought of a deceased donor, and at that time, unfortunately, I mean, deceased donor is an option, but then at that time, unfortunately, Kolkata did not have a deceased donor program. So, Arpita, what is the current status of this deceased donor program in Kolkata and in Eastern India also?
Yeah, in Kolkata, Orissa, and to some extent Bihar also have started doing deceased donor kidney transplantation. Kolkata is little ahead. Yeah, last year we had done 25 deceased donor transplant, and we have done. If we look at the outcome of the transplant, there is 98% patient survival, and death censored graft survival is 100%. So you can see that 1-year outcome is quite good. So we can move for a deceased donor transplant. And what I find that enlisting is also less. We have to push for other nephrologists that get them enlisted in the deceased donor program. And what I was telling you, they can even cross the average year period. The average waiting period may be a little shorter for them. As you can see, there are 13 children enlisted in the deceased donor program in SSKM Roto, mostly from SSKM Nephrology department only. I would request you all to enlist them.
And do they get any advantage?
Yes.
Age advantage?
6, they get extra points depending on their age.
But then we still can't do preemptive listing.
No, we are not yet able to agree, make all people agree
So
that they will be
that is something seriously should be worked upon.
seriously should be worked on.
Angshuman has something to say.
The NOTO guideline says you have to have on dialysis for at least 3 months to be registered on the wait list.
Yeah.
So that's what we are from pediatric nephrology community.
Dr. Gulati is saying
Dr.
yes,
Gulati.
yes, but as a pediatric nephrologist and a nephrologist, I think you are the person who should be changing the rule or try.
Created a liaison committee Georgie Abraham is not here. He is also the president of the Indian Society of Transplant. And Professor Hemant again is a part of the liaison committee. And these people are, I think, Professor Srivastava is sitting here and we have been discussing a couple of points. He's been guiding us. So I think it's time for everyone to work together. The ISPN and the Indian Society of Nephrology need to work together on several points. Earlier during the day, we had the issue of eculizumab. Now is this issue of preemptive listing. No child can be listed preemptively. Arpita is absolutely right. We have been struggling. Writing
So
doesn't.
maybe you can leave this legacy for us.
No, I think work together with the president of the ISN and the ISN as well as the ISPN could work together, jointly formulate a letter. And right, the government is so much on its plate, they don't worry, they are not concerned about transplant. But we have to lobby with them. This is the era of lobbying, let's be honest about it.
So we will
session with the ISOT people. I think that there we have the best thing that half a day Noto session is there.
Hopefully things will improve, and I'm not expecting that we'll come to a decision at this forum now, but hopefully we have highlighted this, and what is very good that we have got the ISN president, the ISOT president, so all of them can be around, and we also had the ISPN secretary Aditi also around, so maybe in future we can move forward more seamlessly. But going back to Anshuman, we didn't have a deceased donor transplant, so what is the other option?
So you have two options, like you can go for a ABO incompatible or you can go for a kidney paired exchange. But since the blood group of the child is O positive, the paired kidney exchange will not be possible because the donor is, we can give to kidney to his or her own relative itself. So the ABO incompatible is a definite possibility. And with advent of plasmapheresis and antibody-specific immunoadjustion, the outcome is quite good now, almost comparable with the.
But the meta-analysis is the same.
The Lancet analysis showed that there is increased mortality in
so
the first
after
3
reading,
years.
I follow meta-analysis. After reading that, I am completely against ABO.
No, but you have to see that the comparison with the wrong population. What is the alternative the child has? The child stays on the waiting list. And the wait list on dialysis, mortality is 30 times higher than normal population.
So what Anshuman is saying again is half a loaf is better than no loaf. So any kidney is better than no kidney. Please, this is true for adult, this is true for pediatric also, please. So that was one of the indications. Paired donor, we have already covered. But in this particular child, they went for the unrelated transplantation and the transplantation happened nicely. So about 9 years, started developing recurrent cholangitis. You remember the child at ARPKD? So recurrent cholangitis. Now they went for liver transplantation, and this is the child now at 12 years with liver and kidney transplanted successfully, doing quite well. Creatine 0.73, liver enzymes okay, and I'm sure all of you will agree that he is a superman. So going from a superman, I would lastly like to go to a story of a super girl. This child came to us around 9 years old, was initially managed at ICH for a month or so, was not improving. People from West Bengal and Eastern region don't really have much faith on us, it seems, and they went over to another center. And there the child had a biopsy, was chronic GN, nothing happened, and was on hemodialysis. This is how the child again came back to us, because they had to come back to their home sometimes. So was pale, anasarca, cold extremities, poor sensorium, stage 2 hypertension. But whenever you put this child on, so the echo and everything was showing that the child was overloaded. But whenever you put this child on dialysis, the BP used to drop to 60s within first hour on HD. It was a real nightmare. Whenever this child has severe orthopnea, this was the echo. You can at that time, you can see hardly contracting. In fact, the cardiologist started the child on anti-clotting because was quite worried that because of this poor contraction, there will be the thrombus in the system. Ejection fraction was 15%. So was having a cardiorenal syndrome like type 4. So this question is for all of you, like, would you accept this child for a transplant?
I think the EF is quite poor. We know that following transplantations with normalization of kidney functions, that improves some cardiometabolic parameters like anemia, fluid overload. But particularly in this child with EF of 50%, she may not tolerate the surgery. So again, it is win-win situations. So you have to decide with the team, maybe team approach.
So then
and
how do
talk
I do
about
the dialysis? PD was not working. Dialysis within an hour, this child blood pressure went down and started having all those symptoms were aggravated. It was complete nightmare. And the family was counseled that you go for a heart transplant. And after heart transplant, we can do the kidney transplant. Father came and told me that kidney nahi ho raha hai, to hum log heart kahan se laye? So it was a real nightmare. What we did was that we initiated this child on daily hemodialysis, initially slate, and then at least 4 to 5 hours daily. And as you can see here, that slowly with the dialysis, the weight came down slowly. It took time, almost more than a year. And the ejection fraction went on slowly increasing. And now this ejection fraction after almost 1.5 years was about 50%. So this something is like many of us might have seen them anecdotally, but then it's not really published that much. That in children with a 15% ejection fraction, and that was not a one of occasion. It was like that for at least 5-6 months, but that it can improve with proper dialysis and intensive dialysis, not really proper intensive dialysis. So now the transplant surgeon and the team was happy that yes, 30-40% ho gaya, we will do the transplant. So I said that we are ready for the transplant. Good, we will have this. The family is struggling a lot, so we will have the transplant. But now we made the big V of poverty. The family said that hum loga jo bhi paisa tha to yehi dialysis mein chala gaya. We don't have a single penny. So I would like to have your opinion that what to do in this sort of a case. So we can start with Angsuman, who works in a Modi's state. So आपको तो पैसा का problem नहीं होता होगा ना?
There is a very good program going on in Gujarat with collaboration of Government of India and state government. So it's called a school health program, and it's completely state funded, like the ESRD care and the transplantation, immunosuppression, post-transplant immunosuppression up to age of 18 years. It's completely state funded if you are a native of Gujarat. And of late, the PMJY also is included. So if you have a PMJY card, that is covered. The initial pre-transplant work.
So then money is not a problem
money
for
is
you.
not an issue.
Subal?
Yeah, same thing for us. We have a state scheme that provides up to 5 lakhs one time, and then also some maintenance medications.
So 5 lakh mein ho jata hai.
Yes.
And expertise, do you have the surgical expertise?
Still again, our surgical team is not compatible. Less than 15 kg. They have done bit older children.
So that part is developing.
Yes, yes.
Arpita ji from Didi's state?
Yes, we have 2 advantages, the Shastra Shati and the PM NDT program.
Huh?
Both the PM NDT, first thing is to overcome the barrier of dialysis.
Modi Kolkata mein paisa deta hai?
We have in all districts, we have, actually Didi doesn't always agree with that it's done by Modi. Didi accepts that it's done by her also. Whoever, we are the beneficiary part. I'm not in struggle between Didi and Modi or Modi alone or Didi alone. But what we enjoy is now that almost in most districts, we have dialysis program, and that dialysis can be done without any cost. So one issue, transplant, yes. Transplant is done without any cost in the transplant hospitals.
And your surgical expertise, are they happy?
Surgical expertise is again same with Shubal in government setup. We don't have compatible with the lower than 10 kg or very risky, just 2 to 5 year old where you find the anastomotic problems most. So those cases are not done in our setup. But what you told, first thing is the dialysis barrier, because we also find this type of renocardiac cases where we find significant volume overload, difficulty in continuing dialysis in the peripheral centers. Then the answer is from the peripheral centers. One other blessing is COVID. We have developed very close interaction with the peripheral centers. They can inform us, we can get him in our dialysis, and every day we can do intensive dialysis, SLADE, everything we can afford in IPGMER. We are doing that and maturing the patient to transplant possible stage.
But you don't have a pediatric nephrologist.
Yeah, don't have a pediatric nephrologist. We will be happy if we can include you or Shumantro in our panel.
Sorry. Pradipta, so you are working in a center which is well equipped to do even a small children, and you have got the expertise. But then what about the money? How do you overcome that?
Well, I have spoken to, and I get spoken to quite a few NGOs, and quite a few of them, I was surprised, they come and do help us. There are at least 3 of them who are very generous in helping our poor population, especially pediatric population, also adults. And our hospital is also on a case-to-case basis do help a certain sect of people, provided they qualify for that.
So the bottom line is, and this is a very important take-home message that and that's what I tell the family also, that money is not a barrier. When they come, they said that paisa nahi hai to hum log kaise kare, but money is not the barrier. Barrier is, we will be discussing now, is later on, that it is the mentality. Money barrier can be overcome. CMRI, in fact, is doing kidney transplantation if you are poor, completely free. And we have got Arpita Di, we have got Subal Center and Anshuman Center, who are also doing it almost free or completely free. Expertise are developing, but money is not an issue. So fairy tales can come true. Really believe me that this child made me very happy. That when this child got transplanted from a no hope situation, and finger crossed, at present is doing quite well. So KT is the preferred mode of KRT in children with ESKD, with excellent short and long-term outcome. Despite its feasibility in most of the children, the rate of KT acceptance is still very low because of multiple challenges. Lack of locally available facilities of pediatric KT, lack of kidney, lack of finance, but I really believe that it's lack of awareness. Lack of awareness among the family, which is, I believe, is very important. But maybe I'm sure everyone will agree, the lack of awareness in the medical fraternity also, that हाँ इतना छोटा बच्चा में भी kidney transplant किया जा सकता है. But then challenges can be overcome. This is the some of the pictures that was drawn by our children from ICH who had undergone kidney transplantation, and ICH doesn't do the transplantation at the moment. We haven't developed that, but these are all our children. They didn't have any money, and with the help of NGOs, we were able to do the kidney transplantation. Thank you very much. And lastly, again, a sincere request for all of you to register for the ISPN Con, which is going to be happening in Kolkata in October. And there's this special discount which will be there for today also. Thank you.
Dr. Sinha, please may I just add one thing. It's not a one-man or two-man show doing pediatric kidney transplants or transplant to that effect. We need a team, as we all realize over here, who have been involved. A wonderful talk by Dr. Gulati, very impressive. Pediatric intensivists, pediatric anesthesiologists, pediatric nursing care. We have been able in our institution in Kolkata to set that up one by one. So this teamwork is very important, and I'm sure all the successful programs who have been doing pediatric, especially pediatric transplants or organ transplants, realize that. So that is the beginning, that we need to have a trained, dedicated team doing that.
Okay, so thank you. If the chairperson has any comment.
Thank you, sir. Today we have discussed a very challenging topic, pediatric renal transplant. As we have seen through multiple case discussion, which were very informative. The need of pediatric transplant, and the outcome is good. And we should not be afraid to saying any these types of pediatric patient needing a transplant. No, we should definitely say yes. There are definitely challenges, but we can overcome. Thank you, moderator Rajiv Sinha sir, and all the panelists for coming here and having a nice discussion.
Thank you very
Thank
much.
you.
Thank you, Dr. Raji, for a very engaging session, going slightly political also, but Bihar is famous for this, so we will take that in the stride. So with this, we will move to the next session. The session is a pediatric CKD, harbinger of adult onset comorbidities. And for this session, I like to call upon the chairpersons, Dr. Pratik Das sir. Sir is a senior consultant, nephrologist, and kidney transplant physician at R.N. Tagore Institute, Kolkata. Dr. S.A. Krishna, consultant pediatrician from Patna. Dr. Pankaj Misra, consultant nephrologist from Ranchi. And Dr. Manoj Gupta, a consultant nephrologist from Purnia. I'll request the chairpersons to introduce the speaker, Dr. Yinsen C. The session will be of 20 minutes and the discussions are for 5 minutes. Chairpersons, please take over the stage.
Good afternoon, everybody. And after a nice discussion on pediatric transplant, now we move on to this Professor Yinsen C, who is a consultant pediatric nephrologist and a clinical director for quality and safety in Great North Children's Hospital, Newcastle, UK. And total experience, he is consultant since 2019. His area of interest is pediatric nephrology and medication safety. And he has lots of these achievements and honors and awards and publication in his care. Without wasting time, I'd request him to start the talk and enlighten us.
Great, thank you very much. I think I and someone else is here between you and lunch, so I'll make this quick. So it's been a delight to have this link with adult nephrology here, and hopefully I'll try to put it all together. So Aristotle once said, give me a child until he or she is 7 and I'll show you the person. And I think hopefully by the end of my talk, I can put it all together and illustrate that. So I always like to start a talk by linking it with a patient. Imagine a 15-year-old girl with a solitary functioning cystic dysplastic kidney, and the kidney function is not too bad. Its GFR is 50, it's 80, she doesn't feel anything wrong. But the question is, what does her future look like, and what can we do as nephrologists, pediatric nephrologists, adult nephrologists to optimize her life? So Kakut, congenital malformation of the kidney and urinary tract, as you all know, is a catch-all term for a number of kidney conditions which are made before a child is born. If you take a bunch of children with CKD, that makes up 50%. It's quite common, 0.5% of live births. It tends to run in families, but not particularly strong. And increasingly, we're finding genes that are responsible or partly responsible for developing CACUT. If you go to adult services, it actually makes quite a small proportion of the work. So maybe it's not such a big focus. And as we were all heard, close working with urologists is really, really important because, you can have patients that are just looked after by kidney consultants and they may forget about the urology side. And similarly, you might have patients only looked after by urologists and they may not see the kidney side. So in kidney development, it starts off very, very early, really before a child is born. And these patients, many of them have quite low nephron numbers. And as they grow up, you may not actually know that their kidney function is compromised because their creatinine doesn't look too bad. And then they have the growth spurt and then they go and live their lives as adults, especially in women. They have huge stresses when they are pregnant, and we may find that they end up with kidneys that are very damaged, after they've given birth. There's also lots of environmental stresses that maybe we can do something about throughout the life to improve their kidney future. Every nephron matters. So we've developed quite sophisticated ways of measuring nephron numbers. And as you can see, once you're born, it's downhill from then. When you're 90 years old, you've only got half the nephrons you were born with. And if you've got CACUT, you start off with a very low level. And as I said, maternal health really matters. If the mother before you're born has deficiency, then the nephron numbers is reduced even further. If you're born premature, if you have neonatal AKI, that really hammers the kidneys. In the AWAKEN study, we found that half of all infants less than 28 weeks have AKI. So there's a double whammy there. So I'm just going to convince you over the next few slides about what CKD progression looks like, what the mortality in young adults are, what we can do to promote health, and maybe how genomics can throw up challenges for us. So CKD progression begins in childhood. We have lots of patients that, they come there like, 16, 17, 18, their kidney, the creatinine looks quite normal. So in Israel, everyone has to do military service when they're about 17 years old, and they've kept really good records. So these are 30-year data. If you have a history of CACUT, then actually 30 years later, your kidney function, significant number of those go into end-stage kidney failure compared to normals. These are people with a history of CACUT. When they are looked at 17, there's no evidence of them having impaired kidney function. If you have a history of pyelonephritis, if you had glomerular disease, your risk of end-stage kidney disease significantly increases. Even persistent dipstick hematuria at age 17 increases the risk of end-stage kidney failure, even though all other markers look quite normal. Even mild childhood CKD can be progressive, especially if you had glomerular disease. So look at the, don't worry about the severe group. Look at the dark green ones. They are the ones who GFR is pretty good. There's no proteinuria, but look, 8-10 years later, many of them reach end stage. So this is from the ERA European Registry. So this is a skill group. These take adults who have reached end stage, and they look back at their progress. So firstly, not all CACUTs are the same. Some subgroups go into kidney failure, quicker than others. The majority of these CACU patients end up needing transplants in young adulthood. This is when they're in their prime. The good thing is that when they do get transplanted, their grafts last longer and the 10-year patient survival is better due to lower cardiovascular risk. There's still cardiovascular risk. And what about young adults who, what are their lives like if they have end-stage kidney failure? So this is 5-year mortality from children who are up to 12, 12 to 20, and up to 30. As you can see, the mortality actually increases a lot as young adults, maybe because of their disease, maybe because of their lifestyle behavior. And a lot of that is to do with cardiovascular risk though. So they're not the same. So this group is quite vulnerable, young adults. This is a big study in the UK, and obviously it's hard to compare different countries. So there's this study, 1,000 young adults aged 16 to 30, and they were asked, what are their lives like? Unfortunately, they're much less likely to be in a relationship. They're much less likely to have children. They're more likely to live at home, still in a family and without a job. Their quality of life is poor. And many of them have psychological issues, but actually they're nice kids. Not many of them smoke, drink, or take drugs, and yeah, they're just nice kids. Increasingly, with longitudinal data, again, this is the Israeli study. Maybe some of the urinary tract cancers are increased, and at a much younger age as well. And maybe that's to do from the ureteric genesis. Okay, so what can we do to prolong the kidney health? And you all know this. So, and I'm just going to show you some senatorial papers throughout the last many years. So this is the ESCAPE study, and essentially they're randomized into okay blood pressure. So these are not children with high blood pressure. Their blood pressure is less than 95th centile, or really sort of suppress them less than 50%. And look, both in the glomerular nephritis group and in the CACUT, you're buying them much more time with prolong their kidney life. So actually aiming for 50th centile is good for kidney survival. Similarly, this was just published, and I was very happy. I was very fortunate to be involved, a UK centre, and this is actually again looking at comparing blood pressure targets, but actually we're looking more at cardiovascular risks. And again, with the intensive group, we're finding so it's very hard to look at cardiovascular risk in children because they don't, unlike adults, have heart attacks and so on. But what we can do is to use proxies such as how thickened the heart is. And we can see that actually with over 5 years, with more intensive treatment, you're getting a better outcome in both groups. And I think one of you said before, if you're in a trial, you always do better, even if you're in a control group. We only showed any significance in wall thickness, but it was still very good. So really, we should aim for about 50th centile in blood pressure in the CKD population, and not just take not being high as okay. Obesity is an independent risk factor, and we've got so this is a quite old study now, and it shows what happens to blood pressure with obesity. So firstly, this is the reference group. If you have normal BMI age 5 and then you become obese, your blood pressure goes up. However, if you were obese at age 5, but you became normal BMI at age 14, your blood pressure normalizes. So we should try to get children to have a normal BMI. But if you are both overweight at age 5 and 14, then you have a double whammy and your blood pressure is highest of all. We saw this before about nephron loss, and look, we don't have data on children, but this is on middle-aged people. Look at how steep this line is. If you have hypertension, your nephron loss accelerates. We know, and I said at the start, we may not think, someone with a GFR of 80, but solitary kidney is okay. This is a big study in Netherlands, and really their definition of kidney injury is proteinuria, having lower GFR, high blood pressure, or being antihypertensive. A solitary kidney, 75% of them have one of those factors. Is high BMI. We saw this yesterday, and as I said before, really close working with urologists. Get them to and simple to. So we've heard a lot the last couple of days about genomics. It can help in getting a diagnosis, but it also throws up some challenges and for us as nephrologists. So in CACUT now, still a lot of genes are unknown, but increasingly this proportion of genes that we do know is getting bigger and bigger. The most common ones are PAX gene and HNF1 beta. Imagine if you do a panel, and this is the UK panel. So if I got a child with kidney disease, I just go down and see which one, and then I get a result in a few months' time. I heard that in India, you'll get a result in a few weeks. We're a bit slow. It takes 6 months in the UK. But imagine you come up with HNF1 beta, which is quite a common condition for CACUT, for this 15-year-old girl. It's also some dominant condition, and 50%. And how it but also pancreas and liver. There's very poor genotype-phenotype correlation even within family. And if you go slightly beyond the gene, you can interfere with things like autism and schizophrenia gene. So there's some link there. And the pie graph on the right shows that from the kidney side of things, it's completely random what you get in terms of what CACUT you get, and also how bad the kidneys are affected. However, if you look on the person graph, they can get early diabetes. So, you've got this information that they've got HNF1 beta. We need to train up the families and the patient to actually look for diabetes. You may be the first to recognize that this patient has quite a high risk of having infertility because of genital tract malformation. So with this knowledge comes some responsibility about what do they need to know, and do we need to look elsewhere to look for other pathology, extrarenal manifestations. So really, how I conclude is that we've got this young lady, kidney function is not too bad, but her future will be best if she has some monitoring for life. We need to aim blood pressure, not just okay, but maybe about the 50th centile, needs to maintain normal weight, need to treat UTIs aggressively, need to look for extrarenal manifestations if you get a gene, psychosocial support is critical. Preemptive transplant, when it comes to it, colleagues, and empower them to know more about their condition. However, on a wide improve maternal health, access to universal antenatal scans could help. And also we need better markers than just creatinine to look for early nephron mass. So I will leave you with that, and I hope that's been useful.
Thanks, Professor C, for a nice and very elaborative description of a part which we commonly ignore. Specifically, we are the adult nephrologist to get a patient in a state of end-stage disease, probably not so looked over the years after resolving a childhood disease, maybe a congenital one, maybe an acquired one. So I have questions back. Suppose a patient is having not any congenital abnormalities, but resolving 1 or 2 episodes of UTIs in very childhood, or a patient having as a post-streptococcal glomerulonephritis that is thought to be resolved. So is the glomerular disease are more dangerous or a tubular interstitial? How do we follow up over the years? You have told, but how do we follow up these patients till you get in the adulthood?
Yeah, I mean, it very much depends on what your healthcare service is like, but they may not need to come to you for follow-up, but they need some kind of follow-up so that they don't develop occult high blood pressure, for example. Look at proteinuria, and I suppose a lot of it is about self-care. If they have episodes of glomerulonephritis, do they know that it may cause their kidneys to get worse? I would recommend, they to have annual screening, annual blood tests, etc. But it may not be possible.
So how do we monitor this GFR over the time? Is the normal course you should increase with time? If the estimation is better, or a calculation measurement is better, and which method do you recommend to monitor the GFR over the years?
Yeah, I mean, I think very much if you've had kidney disease, which is pretty significant, or you're born with kidneys that aren't very good, then at the minimum, maybe annual GFR, annual blood pressure, and an annual proteinuria check. Does that answer your question? Sorry, I wasn't quite sure what you asked.
Do you just estimate the GFR using the formulas, or do you just recommend to do an yearly DTPS scan or a 24-hour creatinine clearance like that?
Yeah, I mean, really, you're looking for quite large shifts. And then I suppose what I'm trying to say is that what you don't want to do is to say, oh, everything's okay, you can go now, and not have any long-term monitoring. Because even in my country, it's quite common for someone to say, oh, your creatinine is kind of okay, you're now 15, 16, you don't need to see anyone ever again. And then 20 years later, they end up with end-stage kidney failure, very high blood pressure, and maybe, things could have been done earlier to have slowed that decline down.
One of my patients has an acute kidney injury due to acute pyelonephritis. He is around 10, 12 years old. Now I have treated him, he has kidney function recovered. Now, should I tell him, hey, you have one episode of acute kidney injury. Now you have to come me from every 6 months for the follow-up. Should I tell him, hey, you are healthy, go back to your school, enjoy your life?
Yeah, I mean, I think it very much depends what your health service is like. But I think one episode of urine infection, as I said yesterday, what I suppose you don't want to do is to have that young person have another episode, but kind of think, actually, it's not such a big deal. For those with, it's all about raising awareness that it is not okay to have episodes of hematuria. It's not okay to have too many episodes of urinary tract infections without, them getting sorted out.
Hello.
Sir, do you recommend screening of all school-going children for detection of proteinuria or hematuria?
No. Well, I mean, so there are some countries who do annual urine dipstick testing. So a one-off school entry dipstick testing, but those tend to be countries with quite high level, and it's very, it costs a lot of money, and you may not know what to do with the results. So I think only in sort of Far East countries, Japan, Korea, and their results show actually if you haven't got a proteinuria, there probably isn't much a benefit, and you need to screen a lot of people to stop one episode of end-stage kidney failure. It's incredibly expensive.
Yes, Dr. Rajiv.
He's going to ask me a hard question there.
Did you cover about the call for mutations and all that? Because now the evidence has come up that even without proteinuria, if you are putting up these children on ACE inhibitors, then long-term outcome is better. So without ACE inhibitors, you will go into ESRD say as at one age, and with ACE inhibitors, even without proteinuria, you will go to ESRD at a longer age.
Yeah, I think it's very hard for us in tertiary care to actually influence, to actually say what one should do with mass screening, especially if there's no first degree relative with hematuria syndromes or Alport syndrome, because they can end up being very expensive for the healthcare system.
So don't you think that that's what I think, that at least if you get a child with microscopic hematuria, at least the initial investigation, at least the parents should be screened, and this child should be screened for 2-3 times at least.
Yeah, correct. So I think if you have macroscopic hematuria, that's different. But if you have microscopic hematuria...
No, microscopic. I'm saying microscopic.
Oh yeah, if you have a microscopic hematuria, if it's a one-off, then it does need to be checked to see if it goes away. And then if there's no family history, then you get in a situation where so there has been quite a lot of studies that show the yield of looking for something is actually very low. So you can spend a lot of money.
But the studies were before the genetic era. Sorry.
Yeah.
They were before the genetic era. So is it changing?
I think we need some economic analysis.
Can you put the child on SGLT2 inhibitor for reducing the progression of CKD?
Sorry?
SGLT inhibitor, emegliflozin, for putting the child on SGPT-LT inhibitor for reduce the progression of CKD.
So what's, sorry, I can't hear about that.
Do you recommend using SGLT2 inhibitor?
Right. Maybe I'm not the best person because I've never had any experience of using that. But perhaps in the future that will come into the pathway. But I think at the moment we're a few steps away from that.
So if you don't not have any question, we conclude the session. Thank you very much.
Great. Well, thank you very much. It's been a delight.
Thank you so much, Dr. C, for this excellent lecture. And like we all save our best for the last, so moving on to our last session, the most interesting one by Dr. Professor Vivekanand Jha, a very decorated speaker. For this, I'd like to call upon the chairpersons, Dr. Ashwini Gupta. Sir is a senior consultant nephrologist at Sar Gangaram Hospital. Dr. Jyoti Prakash, a professor and HOD Department of General Medicine, AIMS Patna. Dr. Preetpal Singh, additional professor, Department of Nephrology at IGIMS Patna. And Dr. Dharmender Prasad, consultant nephrologist at Prasad Hospital, Mumbai, Prasad Hospital, Muzaffarpur. To introduce the speaker and the topic, transforming kidney care with artificial intelligence.
Good afternoon. It's a great privilege for me to introduce Professor Vivekanand Jha for this concluding talk of this wonderful CME organized by a dynamic team of Professor Hemant Kumar, Om Kumar, and all the stalwarts of Bihar. Professor Jha, a very dear friend with whom I have an association for over 4 decades, is a wonderful human being with lot of values, a great teacher, loved by his students and mentor to many. And he is a academician and researcher par excellence with more than 300 papers. And above all, I would say that I have seen many people going abroad, they don't come back. He has not only come back to India, but he has brought back global health care India to New Delhi. And presently he is the executive director of George Institute of Global Health. And he is the chair of Global Health and Kidney. And he's a professor of medicine at Imperial College of London, conjoint professor of medicine at New South Wales University. And he has been instrumental in setting up a tissue culture lab at PGI Chandigarh. And he is the first Indian and probably the first Asian to become president of International Society of Nephrology. So with these few words, I would invite Professor Jha to deliver his talk on transforming kidney care with artificial intelligence. Professor Jha, please.
Thank you, Ashwini. As usual, you are being a dear friend. You are very kind and over generous with your praise and sort of spoil people when it comes to that. But let me also start by expressing my deep gratitude to Dr. Hemant Kumar, Dr. Om Kumar, and all the colleagues of Patliputra National Kidney Foundation and the Bihar nephrology community, which I can say with great pleasure that it has grown and it's become very, very strong now. So the job that Hemant has given me is somewhat different from the kind of talks that you've heard over the last couple of days. And he wants me to talk about big data and artificial intelligence, which are all big buzzwords, but we need to understand them if we are going to be in a position to make the most optimal use of all of these various technologies that are becoming available to us. Just like all new technologies, they have the potential to do a lot of good, but they can also lead us astray at times. And so we unless we know how to harness them properly for our benefit, we can easily go in the direction that is not necessarily one that leads us to a good place. So before we get into the discussion of the topic, let's just try to clarify a few terms. And the first question is often asked, what are big data? Is it something that can be defined in numbers, or is it something that can be defined by some other dimension of size? So the answer to that is that it's all of those, but still none of those. These are large, complex data sets that cannot be managed using traditional software or internet-based platforms. That's the easiest way of identifying what big data is. So when you have the kind of data and the kind of analysis that you want to do cannot be done using traditional tools that we have available. And they often surpass the traditionally used amount of storage, processing, and analytical powers. So we are now having to develop new terms like petabytes. We all know gigabytes, or petabytes, yottabytes, and terabytes, and so on and so forth. And therefore, they require high-end computing solutions for managing them. There are a few qualities that big data are thought to have, and they all start with the word V, which is incidentally the first letter in my name as well. So they are, of course, large in terms of volume. They also are varied. So variety is important quality of big data. velocity, they're produced very rapidly. For example, those who run dialysis units, they know that dialysis machines produce a lot of data, almost on a minute by minute basis. And they are data related to procedure, data related to the patient, etc. But importantly, they need to be of value to us. If they're not of value to us, then it doesn't matter how big the data is. And therefore, for them to be of value, their veracity needs to be proven that, yes, we know that they're good, clean data, and they are able to do the kind of things that we want. And big data is critical to the optimal use of artificial intelligence, to which we'll come in a moment. But the main sources of big data in kidney health community is electronic health records that we are all using more and more. They are more in use in some healthcare systems, like the ones that Dr. Vincent comes from, or my friend sitting here, Dr. Tobias, working in the UK, also comes from. But we are hoping that they will become more ubiquitous in India as well. Billing and insurance claims are an important source of data. But then data are also generated through national programs like population surveys, surveillance systems, census, etc. An increasing number of disease registries and databases are being set up. If you are a researcher, you perhaps have participated in a cohort study or a clinical trial. We all do now laboratory tests, and multiplexing of laboratory tests has become very common. For example, now you send off panels, right? As Dr. spoke about, and various kinds of panels that depends on the phenotype of the patient that you use. But also other type of tests. I'm sure you are now sending out tests. If a patient is admitted to intensive care unit with fever, then you perhaps just send out a panel of tests which perform DNA diagnosis of infections. And we have all of these devices that we wear. Mine is a simple one, but I'm sure many of you are wearing iWatches, Apple Watches, which will generate complex amount of large volume data almost on a daily basis, or almost on a monthly basis, or weekly, even minute by minute. So if we just break the data elements down, they can be of basically three types. There could be very structured data. So you know exactly what is the heading and what is the data that you're going to get in that box. For example, systolic blood pressure, diastolic blood pressure, age, sex. Similarly, you go on. So these are clinical data or electronic medical records. Then there are some semi-structured data. They're not structured so well. And these are claims data. For example, an insurance company, you might file a claim to your insurance company, or a hospital files claims to the government for the services it has provided. So there is a bit of a mix of data, and so it is not as well structured. And then lab reports also can come in semi-structured form. Then finally, we have totally unstructured data. For example, an X-ray image, right? There is no structure to it, but the software has to derive a structure out of it. We have biopsy images. We have clinical notes. Notes are written by humans in their scroll. And then images have to figure out what to make out of those notes to for them to be used in an artificial intelligence algorithm. And once that data has been collected, they need to be curated. So someone needs to do it. It could be a human or it could be a machine. What is the purpose of curation, you will ask? Curation ensures that the data is accurate, it is consistent, it is credible, and it is also timely. You don't necessarily want to use the data which has been produced in a time period which is different from your time frame, right? And we also want to make sure that the data that we have are of high value for any kind of analytics that we want to do. There is a principle that has, and the principles have been developed for curation of data, and they are known by this acronym called FAIR. What is FAIR? The data should be findable, the data should be accessible, it should be interoperable, which means that if it is generated in one platform, it can be used on another platform as well. There was a day when then the Apple world and the PC world was different. Something that you used in a PC could not be used on an Apple device. That is not what we want here. We want, that's just a very crude example I'm giving you, but then operability can be a concern even with softwares. Many softwares don't talk to each other. And finally, they should be reusable. This is just a figure here to give you a sense of the complexity of how do we do this kind of analysis if we are going to be able to use artificial intelligence algorithms. So we get data from a range of sources which are shown here on the left. It goes to data warehouse. And the data warehouse has this, what for us humans or us doctors is a kind of black box. And within that black box, analytics is going on all the time, looking at just describing the data, deriving diagnostic features out of it, trying to develop predictive models, and finally using all of them to come out with some prescriptions, right? And the first 4 set of processes give you an insight into the data, but the prescriptive one will give you some foresight as well. And what we want as doctors or healthcare professionals is improved outcomes by development of smarter and cost-effective decisions. Something similar is just said in a different way here on this slide. We do use big data and artificial intelligence for diagnostics, but very importantly for preventive aspects. Some wise man said that the best hospital is the hospital that doesn't need to be built because we were able to prevent a disease, right? So you don't need hospitals because you prevented that disease. So we use this data and we use this as a mix, like I said, and you heard the talk on genetics here, genetic, lifestyle, and social circumstances. These are all important for disease prevention. We often talk about precision medicine, and precision medicine is not possible at all without big data, artificial intelligence. We are always constantly engaged in research, and the research also needs to be informed by these approaches so that its efficiency can get better. We can reduce waste, we can minimize harm, and we can come out with the best type of solutions. Reduction of adverse medication effects, something very, very important, which we don't pay attention to. We are engaged as kidney doctors in polypharmacy almost on a hour-by-hour basis. Many of you are very busy clinicians. I'm sure you see scores of patients in your clinic every day, and you use, I'm sure, 8 to 10 medications in every prescription. It is impossible for you to remember which drugs interacts with which, or which drug has what kind of side effect at what GFR. And it is here that the predictive algorithms come into play, and they tell us, they warn us. And if we use an electronic prescription system, and if you have done something, you will see a pop-up warning you of possible things that can go wrong with this. And in the end, population health. So again, if you had to remember a few opportunities where we can innovate and improve healthcare through development of data-driven applications in clinical practice, but also in research, these will be a few things. Early disease prediction by identifying those who are at risk. So why this is important? Because when you identify someone who is at risk, you can appropriately target interventions or therapies. You don't want to treat every single individual in the room to prevent diseases that might develop only in 10% or 20% of people. So appropriate prediction is important. Then, of course, you want to go on and make a diagnosis in a timely manner, and diagnosis of a few conditions like the type that Dr. Vincent spoke about and were discussed even earlier, like CT glomerulopathy and all of that. It's not easy to make those diagnoses. And so those diagnoses do require support, and we'll come to that in a little bit, how it can be done. And then data-driven treatment decisions. And finally, research. I come back to research all the time because research is something without which we cannot make progress. So how can the health systems learn by using artificial intelligence? So you have the health problem that interests you or interests a population or interests another stakeholder. It could be a policymaker. A government official can come to you and say, find me a solution to X. So that is the health problem of interest, right? So you start with data. You start with data on the left. Data needs to be used to generate knowledge and also to understand what are the gaps in care. There can be gaps in the care of an individual patient, or there can be gaps in the care of a population, right? And then we take that knowledge and convert that into practice. I'm not going to read all the small text, but you can read it yourself. And then in this, it is here where AI comes into play, because then AI can be used to allocate appropriate resources to high-risk individuals so that those who are most in need are served more than others, and to prevent unnecessary interventions in low-risk patients. I keep coming back to it, and this is the answer to Dr. Rajiv Sinha's question, is that you don't want to just dump something onto the entire population, right? Just because someone has had microscopic hematuria in the family doesn't mean that now you gave ACE inhibitors to everyone in the family. So you have to basically target the interventions. And then using this approach, if once we sort of internalize this approach, we form what is called a learning community. The community is prepared to learn, entire community. And then they're working together to solve problems of interest. And finally, once we have changed our practice, this practice also needs a generation of more data. But this data is somewhat refined, it is somewhat different. And that new set of data once again enters the same cycle. And thereby the learning healthcare system continues to improve over the period of time. Right? So now let's dissect out this issue of artificial intelligence a little more. And there are two other terms that I want to introduce here, which is machine learning and deep learning. These are two important terms which are essential for artificial intelligence understanding. So machine learning is, if you have some data, you can teach a machine to analyze it. So this is called kind of supervised learning. You supervise this and you give that set of data, but you also tell the machine what these data are and what do you want to get out of it and so on and so forth. So that's machine learning, which can be supervised. But then after some time, our hope is, and also that's a big worry, that the machines can perhaps learn to understand data on by themselves. They don't require any supervision, right? So that is unsupervised learning or deep learning. And that is a bit scary also, because you don't know in what direction it is going to go. And this kind of conversation is starting to take place. I don't know if you follow the news or not, but over the last 3-4 months, the news about ChatGPT and new artificial intelligence algorithms and what it can do. There was a very nice, I shouldn't say nice, but very interesting feature that came out of a reporter from the New York Times, having had a conversation with Bing, which is a search engine like Google, right? And the search engine was responding to it, to that person's question, and some of the responses were scary to him, right? Because the search engine said, I want to end the population or something like that, something crazy like that. And so whereas it can do good, it can do harm also. So now, having talked about that in a general sense, let's come back to our field of kidney disease. Where can we use artificial intelligence in kidney disease? We can use that to identify acute kidney injury early, which is where it's being most used, I think, right now of all the kidney conditions. But also in CKD, to identify CKD, predict progression, in dialysis for management of various medical problems that patients on dialysis have. Kidney transplantation, prediction of graft rejection is the holy grail, right? We always want to be able to tell right away which patient is likely to develop rejection or other kind of complications, and therefore optimizing immunosuppressive therapy. Analysis of images in nephropathology, kidney biopsies, there is always a struggle. Where do you find a good nephropathologist? That's not easy. And if machines can help us, that is something which we can really welcome, right? So if you look at this in a conceptual framework, according to this paper that came out by Azra Bihorak, who is one of the leading researchers in artificial intelligence in the kidney field, you can get data from, again, multiple sources. They can be in omics data, genomics, genetics, but also microbiome is something, or metabolomic data that is being generated. You combine it with clinical records, and clinical records again can come from many sources. They can be previous records. You can get demographic information, biopsy samples, physical status, ultrasound, etc. And then patients are generating health data all the time through sensors, smartphones, watches. They use point of care devices. You have your blood pressure instrument which can store data. You have continuous glucose monitors, and patients will report symptoms also. Patient reported symptoms, PROMs, etc. are also very important. And then there are a few methodological issues which you don't have to necessarily worry about. There is classification, and this is where machines will come, right? The machines will figure out what are the endotypes using the omics data. They will classify and cluster the clinical data, and they will use that for reinforcement learning, and patient-generated health data also gets into it. And in the end, what we are looking for is the panel at the bottom. You want to be this machine to be by itself identify conditions like AKD, AKI, CKD, etc. And what are the optimal treatments. So wouldn't it be great if you didn't have to think and the machine just spat out and and a piece of paper which told you this is how you need to treat this patient, right? And of course, monitor symptom-based recovery. Let's just focus a bit on AKI and artificial intelligence. As I said, AI is being used right now in AKI. So Google DeepMind, which is one of the potential big threats or something that can really disrupt human life in future, was used to develop a continuous prediction model of acute kidney injury in the US veterans, in the Veterans Administration healthcare system. And what the researchers did is that they took the AKI-based models to predict stage 2 AKI 48 hours before a rise, 41 hours before a rise in serum creatinine was observed. And they were able to predict a need for dialysis within 2 days, including in those who had pre-existing CKD as well. And what the EHR-based model did is shown here in the third bullet point, really. But the artificial intelligence performance was better than this. And in the end, they were able to achieve a reduced time to AKI diagnosis in adults with a number of predisposing conditions like burns, acute pancreatitis, post-op situations, cardiac disorders, etc. And using that, they have now, again, this is a bit fuzzy, and I don't think you can read it, but you can go to this paper published in the Journal of Medical Internet Research, which tells you what would be a potential pathway of when a test is ordered. On the left side, when a result becomes available, the results is obviously all the results need to be validated by someone. And so that means that the AKI is detected. That will be the first alarm that goes out. And once that alarm goes out, a pathway sets into motion, which involves technicians calling to the ward, a junior doctor getting informed, and the junior doctor deciding whether or not to page a specialist, etc. So that is the standard pathway. And here you can see what is there in the bottom. That is the top pathway, right? That's how it happens right now. But in the bottom, the results are automatically checked by systems. They're automatically take place if needed. But then there is a fair amount of work which is still remaining. And I'm sorry that the contrast is not great on the screen. It looks well on the computer screen here. And the question that we need to ask is, are these tools reproducible? Can they work in all healthcare systems rather than only the ones where they have been developed? Do they improve meaningful patient-centered outcomes? You can do, and you can show that you could detect AKI 6 hours before they could be detected in using a traditional methods, but does it really do anything good to the patient? Otherwise, we can spend a lot of money and still the patient is in the same place. They all require external validation, and they require development. And in the end, the holy grail is that we should be able to identify a potential intervention that is influenced by whatever new methodology we are using, and that potential intervention should lead to improved outcomes. So these are the kind of things which can be informed only by randomized clinical trials. So here is the study which involved more than 6,000 adult patients. So this was a double-blind study, randomized controlled trial, in which electronic health record-based pop-up alerts for acute kidney injury were investigated. And they were actually not able to demonstrate any improvement in the composite endpoint of acute kidney injury progression, receipt of dialysis, or death within 14 days. So even though it looks good, it looks good and shiny, you are getting something automated and everyone is excited, but ultimately it didn't do any good to the patients, right? So the American Society of Nephrology has started this initiative called AKI Now, in which they are going to test artificial intelligence effort for quality improvement in acute kidney injury. If you're interested, the website URL is shown at the bottom, which is at www.asn-online.org/AKI Now. What is of more immediate relevance to us is possibly this artificial intelligence-based decision support system. What is a decision support system? It's a computerized program which is used to support determinations, judgments, and courses of action in an organization, in a business, in a healthcare setting. So this is the typical CDSS or decision support system, clinical decision support system workflow. That again, data comes from various sources, which you have already talked about. It is stored, it is shared, it is integrated, it is analyzed, and it leads to a clinical decision supports. For example, here the computer will analyze, here is a patient who had hypertension, he has a urine albumin creatinine ratio of more than 300, therefore this patient should receive ACE inhibitor. And the computer will automatically check whether there are any contraindications to the use of ACE inhibitors, or are there any drugs that are interacting. Is the kidney function of the patient good enough or not? And then it simply gives you an output. You don't have to think more about it. And again, there is an AI life cycle for decision support also, like the life cycle that I showed you earlier, that we again start with data extraction and processing, undertake evaluation, tune parameters, and perform an explainability analysis. This is really important because whatever we do should be biologically plausible. For example, there should be, and we understand that lower GFR and higher blood pressure are associated with bad outcome like increased risk of chronic kidney disease. So once this is explained, then we train this model, we perform external validation, and we go back to the point of fair data principles. So we perform the fairness evaluation, right? And then we go ahead and then do clinical implementation. After we have implemented it, we validate it prospectively and once again get into it. So having said all of this, it will be remiss on my part not to identify possible challenges to these big data artificial intelligence projects. There is still concern, especially in systems that are still developing, about data volume, ownership. Who owns the data? Does the patient own the data? Does the healthcare system own the data? Does the insurance company own the data? It's a big issue. We don't think about it, but these are big issues. Here we write prescription and we just hand it out to the patient. After that, the patient is on his or her own. They have to go to the chemist and figure it out for themselves, or they go to the lab. There is heterogeneity. Analytic approaches are also not uniform. These data are fragmented. These data are fragmented, and databases are even segregated as well. Data are inconsistent. There can be missing elements, and we have to identify and correct those missing elements. We need to have the right kind of infrastructure, and we need to make sure, as I said a little bit earlier, that the operability doesn't come into play. So again, just going more or less in the same vein, we need to strengthen our data governance policies and frameworks. We need to have good data protection laws. We need to ensure that the proprietary rights are equitable among stakeholders. There is consistent funding for this. And often there is reluctance with the medical community also, who is just used to working in a traditional way. And for building this kind of artificial intelligence competent workforce, we need to have people who understand computer science. It's my belief that if there are two things that we need to teach our medical graduates even before they start MBBS training. One is mathematics, so that they understand basic principles of data management and uncertainty. And second is they need to understand some degree of liberal arts and human knowledge. So we do leave people who have the nephrology domain knowledge, but the other type of domains are completely missing in our healthcare system. So therefore, often the question is asked, is a computer superior to humans? The answer to that, of course, is not at this point. But if you have a human intelligence, combine it with use of computers or artificial intelligence and apply scientific methods, you will end up with humans who have bigger brains or more knowledge, And in the end, what we are looking for is a computer system or a data system, which typically has narrow intelligence. It is good at identifying trends and making predictions using those trends. It has indefinite memory, and it can identify patterns. And if we apply that and combine it with scientific methods, then you will have hopefully something with wider intelligence, which is what our humans are. So you have your baby who's even 2 months old, so you can imagine sometimes how much intelligence they have, but they are immediately able to identify who are their parents, grandparents, their toys, etc. If you give that to a computer, the computer will not be able to do it. The computer has to be trained a lot in order for that to be identifying individuals, right? There are a number of enablers. Thankfully, we are getting there. We have devices, sensors, wearables. We have digital therapeutics now. nutrition trackers, personalized healthcare is becoming more ubiquitous, like these decision support systems. Telehealth is something we became very familiar with during the COVID pandemic, remote patient monitoring, care, etc. And we are using more and more health technology. But before we go, something which is really topical is the use of these healthcare chatbots. I don't know if any of you have ever been confronted by your patients. So what are these healthcare chatbots? You will ask the question. So these are automated tools which are designed to simulate an intelligent conversation with human users. You have used IVRS, right? You call your bank and you get some prompts. Dial 1 for this or 2 for that and so on and so forth. This is a much more refined version of that. And during COVID, this was used. So this is a platform called COVID Asha platform. And these healthcare chatbots, I won't go into details because we have already run out of time. You've heard the bell. But these kind of chatbots are potentially going to be useful in a number of places. And these are 5 potential what are called use cases, that this is where we can use them for providing informational support, scheduling appointments, collecting patient information, providing medical assistance, and assistance in refilling prescriptions, which is something which we don't do here in India because our patient just goes to a chemist shop and buys these things. Therefore, my dear friends, in conclusion, big data can provide key information about disease burden, mechanisms, risk factors, etc. But when we combine artificial intelligence and machine learning, it can be used for early diagnosis, prognosis, clinical decision support, etc. Data curation is important. Big bad data in, bad result out. We need to standardize it. We need to make sure they're interoperable. They can be consolidated and exchanged. Very, very important. We are all hoarders of data. We keep our data to ourselves and we nurture it even closer than some of the valuables that our family has. You know, it's important that we share data. Only then can this field improve. There is a large scale acquisition of annotated data. There are going to be advances in machine learning. Open source computational packages are becoming more and more available. There is affordable. So your smartphone now has more computing power than the computer that I started using it when the first computer that I used in the 1990s. But then there are a number of challenges also, but we've discussed some of those challenges, so I won't repeat it. And we need to, as a community, address those challenges if we have to get the most benefit out of the artificial intelligence and machine learning and big data promise that is there in front of us. Thank you very much for your attention. I apologize for running out of time.
Thank you, sir, for your nice delivering the lecture on a new topic of artificial intelligence. We must have definite role for clinicians and even researchers in the field of treatment of nephrology. So I think it will help us great in diagnosis, management, and also in the prognosis of the disease. And I just
definitely this is a leap forward, but with a caution on how they will behave, their policies, and definitely, as you said, ethical issues need to be taken care of. So now house is open for these suggestions or any comment.
Enlightening talk. So my question is, the chat GPT is freely available now as a software, and people have started citing it in scientific journals. So your comments about the ethical aspects and the ramifications of it, if somebody uses it for scientific writing.
Right. Thanks. That's a very important question. Chat GPT, I don't know how many of you are aware of it. I'm sure many will be. And the answer to your question is not easy because this is hotly being debated in the scientific community right now. Can Chat GPT be added as an author to scientific publications? I have used Chat GPT, and sometimes you are really amazed, impressed, and sometimes scared by the kind of outputs that you get because they're so good in many ways, right? So should they be credited as authors? I think the community will eventually decide, because the decision has to be something of a consensus that everyone buys into. It won't work if 4 journals accept it and 10 journals don't, or funding agencies. So it takes me back to this particular slide. is this is what Chat GPT for me is at the bottom. You can get something out of Chat GPT, but you have to apply your own brain to it. You have to you have to understand what it is trying to say. If you combine it with your own intelligence, then perhaps you will get the most value out of it, right? But it is a huge enabler. But like I said, going by the experience that was reported by the New York Times writer, it can be scary also. And actually, after that report came out, Bing has taken its Chat GPT-enabled search engine offline right now. So Chat GPT is available, but it's work in progress. It is there. It's not going to go away for sure. And just because the Chat GPT decided to release its product, Google and Microsoft, they sort of had to rush in and come out with something. And therefore, the Bing product, which is the Microsoft product, turned out to be perhaps not optimal. And so they've taken it off. It will come back, and it will come back as hopefully something better. We need to know how to use it. So it doesn't, I think we live in a world where you can't afford to be a Luddite. You have to live, you have to learn to use technology. If you're not going to use technology, not only will you be left back, you'll be perhaps trampled over also by people who are going to run over you. Not only because they will get to a faster place, but you will just not be equipped appropriately to manage even your own daily work, because your work would have changed by that time.
Thank you, sir. Thank you.
Thank you very much, sir, for this excellent presentation. Can I take a minute?
Dr. Urmila.
So actually, I tried again Chat GPT. It's now coming with a disclaimer that I'm not supposed to do this and all those things. And we still downloaded a report. If you do a plaque check, you don't cut across, because Chat GPT takes things from many places. If you improve your plagiarism check, the article fails in journals.
Yeah, so there
have to find out ways not to.
Yeah, there are ways to detect which chunk of text has been generated by an artificial intelligence algorithm,
Yes, sir.
or whether it has been written by a human. So there are ways of doing it. But the point is not to say that Chat GPT is a bad thing. Chat GPT is a good thing. And these kind of algorithms are good. We have to know how to use them. For example, everyone, once you get senior enough, you use a junior colleague to do the research for you. So Chat GPT is your junior colleague. It is doing it for you. If you mindlessly just let it go out under your name, you are the one who are going to receive the blowback. It's more or less the same thing. So look at what the output Chat GPT gives you, and then you decide what you want to do with it. You may just decide to junk it, or you may decide to use just a portion of it, or it gives you some insights which you want to then follow up on and perhaps go to the kind of rabbit holes that you don't have time to otherwise find for yourself.
Thank you, Professor Vivekanand Jha, for a very, very thought-provoking lecture. And message is computer, brain, and scientific knowledge. And you should know how to use the technology. I think that will be the best way of summing your wonderful lecture. Thank you so much.
May I ask Dr. Jha one question, please? I just wanted to, it's not now for the last 10, 20, 15 years, there has been a great advancement in robotics as regard to surgery. It's not only the Da Vinci system, there are other systems that have come in and using artificial intelligence in a very, very, very nice manner, where they're trying to
I'm sorry to interrupt, sir, but if you can get to your question, because I have to catch a flight. So if you can get to your question quicker, I will be able to answer it.
The question is that, there are certain implications of artificial intelligence used in medicine, and using the robots is one of them. So I want to imply that your talk definitely was very, very a great amount of wisdom, but artificial intelligence has to come in in medical in medicine in a big way in the coming years.
Oh, I can 100%. I can only agree with you 100%.
With this excellent lecture, we come to the end of the academic session of this scientific extravaganza. And now I invite Dr. Professor Om Kumar sir for a few words before closure of the session.
So thank you very much. You all will agree that we had a very good 2 days of academic feast. And for this, we congratulate especially Professor Hemant Kumar, the chairman of organizing committee, and President Patliputra Kidney Foundation. I am very thankful to all the speakers, the faculties, chairpersons, and the delegates present in this hall. We thoroughly enjoyed your presence, all the support staffs, and if we have erred anywhere in providing hospitality and providing anything to us, kindly forgive us. And we look forward to meeting you in future for such programs again. Thank you very much. Thank you very much. Thank you. If lunch is ready for all the delegates and faculties, and if anyone from the audience wants to speak anything, they are welcome. Briefly, Dr. D.S. Ray. Professor R.M. Srivastav, sir.
So once again, I express my deep gratitude to the Zone ISN for this program and your very kind hospitality. This indeed was a unique experience. I was a landmark meeting here, and I hope this will be repeated in future also. I again urge my colleagues here to support pediatric nephrologists, either in practice or in the medical schools, medical departments, to encourage them to set up, just to encourage them somehow to come to you and take your help in this. I've been trying to do this to our own people, but there is some hesitation. I hope this will be overcome, and there will be more cooperation there. I think we have a lot to learn from you, both ways probably. There are a number of problems which we have, and we need your help to solve them. Again, my deep gratitude and thanks.
Dr. Hemant Kumar, Dr. Om Kumar. Dr. Hemant Kumar, Dr. Om Kumar, and all the people who are involved in this. We all enjoyed very good hospitality as usual. Whenever we think of Patna, we think of the hospitality you provide, and content and good choice of speakers. So it has made it very successful. Thank you for that.
Yeah, lunch is arranged in the first floor, Utsav Hall. So please go to the Utsav Hall, first floor.
हटा देना ले 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 वो हटा दे ले ले ये हटा दे ये हटा ना